Medical University, Lucknow. Dr. Ajay Patwa. Welcome, sir. Request you to please take your chair on the chairs available next to the podium. I request Dr. Alok Gupta to join us, Senior Consultant Gastroenterologist from Kanpur. And Dr. Prashant Katiyar, Consultant Gastroenterologist, Director, Elite Hospital, Lucknow. Welcome, sir. For the first topic, we have chairpersons, and I invite Dr. Avinash Singh, Consultant Gastroenterologist from Gorakhpur, to join us on the dais. Dr. Ravi Anand, Consultant Gastroenterologist from Lucknow, and Dr. Anand Prakash, Director, GI Surgery, Medanta, Lucknow. And we are all set to go, and I turn the time over to the moderators to invite the first speaker and introduce him. Thank you.
Good afternoon. So, some change in theme and interesting topics to come. We have got 4 stalwarts from the field of endoscopy who will be speaking in this session. First speaker is Professor Praveen Rai from SGPGIMS Lucknow. He is a dedicated endoscopist and he is always there to bail us out in difficult situations. He will be speaking on third space endoscopy, understanding and mastering the art. Professor Praveen Rai.
Very good afternoon. I'd like to thank Dr. Puneet Mehrotra, Dr. Rungta for this wonderful opportunity. So I've got 15 minutes to talk about third space endoscopy, understanding the science and mastering the art. So as you all know, the first space is predominantly the GI lumen, while the second space is the peritoneal cavity. So what is this third space? So third space is primarily in the submucosa. It's a potential space that you create. So what happens in the submucosal space is the presence of areolar tissue, as well as you can see the vessels traversing from the mediastinum through the muscle layer and then in the submucosa going to the mucosa. So this is what the submucosal space, that is the third space, is, which is now a potential space in which we do a lot of interventions. So it's very important to remember the history. So 2007 GI endoscopy, this was the first report by Sumiyama et al., who introduced this concept of mucosal flap safety wall. And following this was Dr. Paschericha, published in 2007, again in an animal model about submucosal endoscopic esophageal myotomy. However, it was only in 2010 when Professor Inouye did the first human case of eclasia cardia through per-oral endoscopic myotomy. So what all does this involve? This involves eclasia, for which you do POEM, subepithelial tumor, for which you do a submucosal tunneling and endoscopic resection. For gastroparesis, it's gastric POEM. Zenker's diverticulum, it's Zenker's POEM. Esophageal diverticulum, you have D-POEM. Esophageal stricture, it's Poiter, I will come to that. Hirschsprung disease, PRAME, and Parkinson's disease, dysphagia, C-POEM. I won't be able to cover all, but I'll touch upon the most important ones. So this potential entry into the third space is primarily because of improvements in instruments, knives, closure device, and hemostatic devices, while the technique, which is primarily the submucosal endoscopy with mucosal flap. So these are the 2 things which has made this third space endoscopy possible. Just to give you an idea, we have now better vision, which is transparent cylindrical caps which are attached to the tip of the endoscope, or the tapered caps. Then we have very high definition scopes which can pick up small vessels, so you don't cause the problem of bleed. We have better electrosurgical knives, and these again are different knives for different procedures. TT knife is the most common one that we use for POEM. Again, hybrid knife is also used for POEM. Then we have hook knife, IT knife. Hemostatic devices, what is most important is the quag grasper. This is what we use on the left. So this is a hemostatic device, and then you have to close the incision with clips, which can either be endo clips, over the scope clips, or endoscopic suturing device. So just to give you what this submucosal endoscopy is, you have the mucosa, then you have the submucosa, and then there is a muscular layer. So what you primarily do is to give a submucosal injection, elevate mucosal incision, it's elevated, and then you incise it, and then you enter into the submucosa, you dissect the submucosa, and then finally you cut the muscle. So this is what the whole procedure is. This is what is done in POEM or GPOEM. If you have a submucosal tumor sitting there in the muscular layer, you can even resect it through this tunnel, and this is known as submucosal tunneling and endoscopic resection, briefly known as STIR. Then after you have done the job, you need to close the mucosal incision with the help of clips. As I mentioned, different clips are available. This is the most common hemostatic clips that we use for closing this incision. So this is the safety valve I am talking of. Here you incise the muscle some distance below the incision to avoid a free perforation. So POEM technique, again, it involves a lot of devices. You need to do a pre-anesthetic checkup, electrocautery machine, then you need a water jet, that is mandatory, then cap for distal attachment that I showed you, knife I showed you, crack grasper I showed you, and hemoclips I showed you. So technique primarily involves making an incision after elevating with fluid, incision in the mucosa, then you enter into the submucosa through dissection. I'll come to the video as well. And then once you have dissected below the G junction and around 3 centimeters into the stomach, you start doing a myotomy around 2 centimeters below the site of incision, and this myotomy is extended 2 to 3 centimeters in the stomach. So this is what the POEM technique is. This is how we do it. So this is incision, injection, that is you inject fluid in the mucosa here. As you can see, you will find a bleb coming up. So once you have a bleb which is achieved, this is the bleb, around 10 to 15 ml of saline is injected with methylene blue, and then you do a mucosal incision which is around 2 centimeters long incision. This is what you are doing here. So incision from below upwards. So once you have a linear incision done, you try to enter into the submucosal space, and this is how you do it. So what you do after incision, you undermine the edges here for letting the scope to enter into the mucosal, into the submucosa. So here you try to undermine the edges properly, and once you do this, after this you pass your scope inside this potential space. As you can see, we are first undermining it properly, and then we are entering into the submucosal space. We have entered, and once you enter, you keep on injecting fluid in the submucosa along with methylene blue. This is primarily to discriminate it from the muscle, and then you keep on doing the submucosal dissection to reach below the G junction. And once you have done a complete tunnel, as you can see, this is a tunnel in the submucosal space that you have created, and once you have done that, you need to do a myotomy, which I said it has to be around 2 centimeters below the site of the incision. This is the muscle that we are cutting right now. So this is the longitudinal muscle that has been cut. This is the adventitia that you're seeing, and after that is the mediastinum. So you do this dissection lower down below the G junction. So this is what the whole procedure is. Once you have done this, you need to close the incision side with the help of clip, so to avoid the perforation, and this is what you are doing in this video. You apply clips. The number of clips will usually be 4 or 5 or sometimes more if the incision has extended. So this is what the procedure of POEM is. Few things are very important. One is orientation. So you can do an anterior POEM or a posterior POEM. There is no consensus which is better. However, posterior POEM has fewer adverse events, shorter mucosal closure time. Anterior one preserves the sling fibers, and there is a lesser incidence of GERD. This is what is proposed. The length of a myotomy in the esophagus has to be 3 to 5 centimeters. That is known as short myotomy. In the stomach, it has to be 2 to 3 centimeters below the G junction. If you don't cut more than 2 to 3 centimeters, or if you cut less than 2 centimeters, there is a chances that the patient will come back with recurrence. And selective myotomy, that is cutting only the circular muscles, leads to lower incidence of GERD, while full thickness may have a higher incidence of GERD. What are the results? If you see the studies, patients, 15 to 1500 patients, clinical success 70 to 95%, and the follow-up, as you can see, 10 years follow-up is also reported here, and reflux esophagitis, which is a most concern as of now, varies from 3.6 to around 49%. So traditionally we are used to do a pneumatic dilatation. So how does it compare with pneumatic dilatation? This slide is very, very important. This is published in JAMA 2019, and this slide tells you this is a randomized controlled trial of 64 and 66 patients. This tells you that the treatment success was significantly high in POEM, that is 92% vis-a-vis 94% only in pneumatic dilatation, and p-value is statistically significant. However, the problem is of reflux, 41% in POEM and only 7% in pneumatic dilatation. I'll come to reflux later on. 2 serious adverse events, perforation, which happened in patients who underwent pneumatic dilatation. So the conclusion of this study is POEM significantly higher treatment success at 2 years, consideration of POEM as an initial treatment option for patients with eclasia cardia. So very important. Second is the Heller's myotomy. I'm sure some surgeons must be here. So this is again a randomized controlled trial published in NEJM 2019. What it tells you, this was a non-inferiority trial. Again, number of patients, as you see, 112 in POEM and 109 in lap Heller's. And at 2 years of follow-up, there was no difference. So POEM was non-inferior to lap Heller's. Serious adverse events, POEM around 2.7, lap Heller's 7.3. If you see the reflux esophagitis, very interesting. At 3 months, POEM 57%, lap Heller's 20. However, at 1 year, the POEM reflux decreased 44% versus lap Heller, which was 29%. So POEM was non-inferior to lap Heller's with fundoplication in controlling symptoms of eclasia at 2 years of follow-up. However, reflux again was more common in patients who underwent POEM. So again, coming to the next, that is STIR. So STIR is primarily, as I mentioned, submucosal tunneling and endoscopic resection. What you do predominantly is you incise the mucosa. As you go into the submucosal space, you try to dissect this lesion. This is what submucosal tunneling and endoscopic resection is. This again video shows the same. As you can see, this is a lesion at the region of the cardia, just at the level of G junction, elevated area. So you do an EUS, you confirm that this lesion is arising from the muscularis propria region, and what you are trying to do is STIR here. So you inject, again, the same incise, enter into the submucosal space, and then here you see, you are seeing a lesion below here, and you try to dissect this lesion, separate it from the muscle if it is attached to, and take out the lesion in total from this tunnel through the mouth. So this is what the STIR is. So this whole lesion is out, and this is a leiomyoma. So this whole lesion will come out, you grasp it with a Rothnet, and you can remove the whole lesion, and again the incision needs to be closed with clip. So this is what you do. So again, what are the results? Again, this is a systematic review and meta-analysis 2017, 28 studies, more than 1,000 patients, complete resection in 97.5, en bloc resection in 95%. So benefits of STIR compared to the other modality is maintains the mucosal integrity and allows for effective wound healing, decreases the incidence of perforation. And how does this compare with surgery? Clinical outcomes are similar. STIR, shorter procedure time, shorter hospital stay, and decreased medical cost. Coming to the next procedure, that is a G-POEM. Again, we have many options that are being offered for refractory gastroparesis. So right now what I'll be discussing is only G-POEM. So G-POEM is predominantly what you do is, again, similar to POEM. You go 4 centimeters proximal before the pyloric orifice, make a tunnel up to the pyloric orifice is what you're doing right now. You inject you incise, and you enter. Obviously, you have some amount of bleeding here, stomach is very vascular, and you enter into the submucosal space here, making a tunnel, and once you reach, you can see this is a pyloric ring which you are seeing right now. You dissect this pyloric ring or incise this pyloric ring for around 2 to 3 centimeters length, and this is what the G poem is, gastric poem, and you close the incision obviously or with the help of clips. So we do this procedure, and what are the results? Again, if you see the studies, patients varying from 200 to around 500 patients, procedure time around 50 to 70 minutes, follow-up ranging from 1 to 18 months, success is very high to the tune of 100%, clinical success varies from 70 to 84%, there are some complications, this varies from 6 to 12%. So again, the next is Z poem. Z poem is primarily Zenkel's poem. So it's primarily, as you know, Zenkel's diverticulum is a pulsion diverticulum in the pharyngoesophagus. So this is what it looks like. If you resort to surgery, the success rate is 80 to 100%. However, there are adverse events to the tune of around 30% with a mortality rate of 3%. Again, very high. There is a procedure known as flexible endoscopic septal division. The problem with this procedure is there is a high recurrence rate of to the tune of around 35%. So these two available modalities to what we have right now is a Z poem. And if you see this Z poem, what it does predominantly is you reach to the level of septum. Again, a mucosal incision, which is injection and then incision around 2 centimeters proximal to this septum, and then you do a submucosal dissection, and finally you encounter this septum, see this septum from inside the tunnel, and then cut this septum. So this is what it is, how it is done, and then finally you close the opening with the help of clips. So what are the results of Z poem? Again, a meta-analysis, 11 studies, high technical success, 96%, clinical success, 93, adverse events again do happen, 12%, recurrence again less, that is 11%. So coming to Poiter, so this is again only few case reports have been reported. So what I will just tell you is the procedure is again, as you do in poem, you enter into the submucosal space above the site of the stricture, and submucosals, and from below, if you have a peg, you need to do a gastrostomy here and move a scope from below. And then what you do is you make this tunnel deep down to the level of the lower end of the stricture. Finally, you pass a wire and then you deploy a stent. So what you have, stent in the lumen going into the submucosal space and again exiting here below. So this is what the Poiter procedure is. However, only few cases have been reported in the literature, but the point is it is possible. So adverse events, again, you use CO2 here, we don't use air, and gas-related adverse events, that is CO2-related adverse events do happen. Subcutaneous emphysema, as you can see in the arrow, this is capnothorax, what you see to the tune of around 6%. Mediastinal emphysema can happen. Capnoperitoneum, pericardium, you can see air around the heart. Then this is capnoperitoneum, air in the peritoneum. Retroperitoneal air, you can see the kidneys being delineated. However, only 6% of the patients need interventions, and the interventions primarily involve gastric decompression, temporarily stopping the procedure, increasing the posterior and expiratory pressure, giving 100% oxygen in the fresh gas flow, and needle drainage is needed only if after these measures, if the patient is still symptomatic, then you resort to needle decompression. Mucosal injury 2 to 8.5%, significant bleeding again rare, up to 1.4%. GERD again, earlier it was thought to be, the incidence was thought to be high. Now this is a new study which says the incidence is only to the tune of around 16% symptomatic GERD, while LA grade C is to the tune of 7.5%. So for this you have poem F, that is fundoplication. I'm not going to in the details of this. What I want to convey here that a fundoplication can be done endoscopically and has shown good results. So to summarize, the third space endoscopy is one of the most rewarding innovations in the field of therapeutic endoscopy in the recent era. Indications for third space endoscopy are rapidly growing because of non-invasiveness. Adverse events are relatively uncommon, and when they occur, they are usually successfully managed in a conservative manner. It may result in diminished role of surgical intervention, and however, long-term efficacy studies and randomized controlled trials are required. Thank you.
Thank you, Dr. Praveen. We can have few questions from the house. We have some time. Yeah.
Thank you, Dr. Praveen Rai. I am Dr. R.B. Singh, surgeon. No questions, but one comment. Actually, you said a conservative way, non-surgical way. Actually, it is surgical way, mini-surgical way performed by the physician.
Okay. Dr. Praveen, like how common is reflux in your patients, and what measures do you take to prevent that? I mean, whether that is helpful or not?
Yeah, so I think a very, very important question, and as I showed you in one of the last slides, that again a large study of large number of patients reported from Japan, the symptomatic reflux was to the tune of only around 15%. As far as our experience is concerned, so the data that we have is that the symptomatic reflux is to the tune of around 20%. However, having said that, it's very easily controlled with PPI. You give a PPI and the patient is totally, does not have a problem of reflux, so easily controlled with PPI. I think we still need more long-term follow-up of these patients, what exactly happens, because the problem is, if the reflux keeps on happening, then there is a chance of, say, reflux esophagitis leading to Barrett's esophagus. So this data we don't have, whether how many of these patients really develop Barrett's. But as I mentioned in the passing about fundoplication, so this fundoplication can be offered as a first step initially. Just in the time of the procedure, when you're doing a poem, you can do a poem F as well. Yeah.
Yeah, but you said like with time, this incidence decreases also.
Yes, yes.
Thank you, Dr. Praveen.
Yeah. Yeah. So I think very, very important observation and a very important question here. So if you see a diverticulum after you have done a poem, possibly you have not done a good job. The LS pressure is still high, and that's the reason why a diverticulum is formed. So I think we have seen out of, I think 100, maybe around 3-4 patients who had come back with a diverticulum when we did a repeat endoscopy as well as a manometry. So probably incomplete division, LS pressure still high, leads to the formation of a diverticulum. Yeah, so I think if obviously if anything that needs to be done is if the patient is symptomatic. So if the patient is symptomatic, you can choose to do a redo poem, or there is always an option of doing a dilatation at that point of time. So these are the two options. Thank you.
Thank you, sir. And please don't go. Please wait, sir. We will invite you on stage for a felicitation. I request the chairpersons and moderators to jointly felicitate Dr. Praveen Rai for such a wonderful presentation. Big round of applause. It was advancing knowledge and improving lives. And I thank the chairpersons for gracing the dais. And for the next session, I am delighted to invite the chairpersons on stage. Next session, chairpersons are Dr. Shubhra Mishra, consultant gastroenterologist Gastro Liver Hospital from Kanpur. Dr. Gangadhar, Consultant Gastroenterologist, RML Hospital, Lucknow. Dr. Pankaj Kumar, Assistant Professor, Department of GE Medicine, SGPGIMS, Lucknow. And Dr. Pradeep Joshi, Consultant GI Surgeon, Regency Hospital, Lucknow. Over to the chair.
Yeah, so next speaker is Dr. Randhir Sood. Sir is Padma Shri, Chairman, Vedanta Institute of GI Sciences and Hepatobiliary Sciences. Sir is Doyen of Endoscopy, and he'll be speaking on failed CBD cannulation, what to do. Sir.
Thank you for kind words. Good afternoon, dear friends, and my thanks to UP ISGCon Steering Committee for inviting me here, particularly Puneet. And I just took over the term of Gaurav. Thank you for giving me chance to present before you, because I have a flight to catch. So my job here is to talk about what do we do when we fail in cannulating a bile duct. This is mostly a technical talk, and I'll be showing videos on how to approach a situation like that. So first, what is standard cannulation? When you cannulate the bile duct with a cannula, sphincterotome, or a wire guide, it is known as standard cannulation. And what is cannulation? It's an intentional continuous contact with the ampulla so that you want to enter the ampulla. And increased cannulation time, increased number of attempts, or injection into the pancreatic duct, these increase the risk of post-ERCP pancreatitis. And the data has shown us that nearly 97.4% successful cannulations are achieved in first 5 minutes. So if you have not achieved it in first 5 attempts, then it is unlikely that you will achieve it continuing the same technique. And that your increased risk of post-ERCP pancreatitis will be more 2 times if you continue with more than 5 attempts. So you have to adopt a technique which is safer. And why do we fail? Because each papillae is, God didn't make a single type of papilla. Possibly it gave the contract to various manufacturers to make papilla for humans. So they made different kind of papilla. And the regular papilla is what we call type 1 is classic papilla. Then the flat papilla, which is less than 3 millimeter in diameter, that's type 2. Then there is long intramural CBD, where the papilla becomes pendulous and is overhanging. Then type 4 is a papilla which is creased, and there is a long ridge below the papilla extending into the duodenal mucosa. And there is a good intra-observer and intra-observer agreement when they come to the type of papilla. Just to give you examples, these are the standard papillae, and these are small papillas which are difficult to cannulate. Again, if the intraduodenal CBD is longer like this, then it looks very attractive, looks very tempting. But these are the patients where you will tend to fail, because this intraduodenal CBD, when you're trying to cannulate, gets kinked and you are not successful. And this is the rich type of type 4 papilla. And this is just the prevalence. How frequently? Fortunately, the typical papilla is present in nearly 60% of the patients. But the failure rate is related to the type of papilla. The type 2, which is the small papilla, and type 3 have the highest failure rate. If you have a long intraduodenal CBD, or if you have a small papilla, then you are likely to fail in this. And this is the standard cannulation technique which we do, that we go with it. Today nobody goes with the cannula, we all go with the sphincterotome. It may be a single lumen, it may be multi-lumen. Normally we choose a sphincterotome which has got more than 1 lumen, so that we can put a guide wire through it, and we try to enter in the upper part of the papilla. So because the CBD takes this turn, it goes from if you take this as the papillary orifice, it will be from 11 o'clock till 1 o'clock that the biliary opening will be, and we try to guide our catheter to that or the guide wire, and the pancreatic duct takes a straighter course in the distal part, and so in the proximal part where it originates from the papilla and where it is draining into the papilla, so we tend to go straight into the pancreatic duct, and that's how we predetermine where we want to go. This is just to give you an example of the standard cannulation. You see, we see a nice papilla here, though there is a long interdural CBD. One thing you must not do is, do not try to impinge your device, whatever you use. Here we are using sphincterotome, too hard into the CBD. Here we were bowing the sphincterotome and it entered the bile duct, and we could perform papillotomy. So what is difficult biliary cannulation, which is the topic for today? Inability to achieve selective biliary cannulation by standard ERCP technique within 10 minutes or up to 5 cannulation attempts. This we should always bear in our mind. And in addition to this, I always say that if you have had more than 1 or 2 cannulation to the pancreatic duct, you should consider it to be a difficult ERCP and difficult cannulation, and should take the proper steps. The ESG defined difficult cannulation as more than 5 minutes rather than 10 minutes, more than 5 attempts, and more than 1 PD contrast or cannulation. So they were a little more stringent, and cannulation is difficult in 10 to 30% of the patients. So what do you do when you fail? We must not forget this. The patient safety is the first thing, and it takes precedence over our desire to succeed. The problem is when you're young, you don't want and your peers to say that, oh, he couldn't do an ERCP, he couldn't cannulate. Always remember, if the patient is safe, you will be able to do it next day. But you never compromise patient safety. Immediately start taking preventive steps for post-ERCP pancreatitis, because now you have entered into a danger zone, and give rectal indomethacin, because in fact, every patient undergoing ERCP should have rectal indomethacin before the patient is taken onto the table. Only exceptions are elderly patients with malignant obstruction of the distal malignant obstruction. They have very low risk of pancreatitis, so they can be exempted from this. Otherwise, everybody, without fail, it doesn't cost much, it doesn't take much effort, but it prevents pancreatitis. And if you are getting into the pancreatic duct, prepare for pancreatic stenting, and please hydrate your patients. This is the biggest mistake we do, that we keep the patient fasting. You come overnight fasting, and then you're scheduling the patient. Patient has not eaten anything, patient has not taken any fluids, and you are doing it at 1 o'clock, and patient is dehydrated. There's enough evidence that if you hydrate the patient in the well, then the post-ERCP pancreatitis incidence is low. Please take these steps and change your cannulation strategy. Repeat the procedure after 24 to 48 hours. If you have significantly traumatized the papilla, do not keep on persisting with it, and seek help of more experienced colleague. It is never a humiliating thing to ask for help from a more experienced colleague, and learn advanced techniques. So how do you increase your competence level? You get yourself trained in various cannulation techniques, which I am going to show you. And the most important thing is, if you are in the pancreatic duct, because ultimately the biggest threat is pancreatitis, please secure your pancreatic duct, and while cannulating the bile duct, either with guide wire technique, that is double guide wire technique, or putting in a pancreatic stent, 5 French pancreatic stent. Learn a safe technique of pre-cut, and if that all fails, then you have an option of doing EUS guided bile duct cannulation entry, or PTBD, which we used to do earlier, but now we are going only for EUS BD. So let me give you some examples. This is a patient who has got a type 3 papilla. There is a long intradural bile duct. There is a and here there is a difficulty in cannulation, and I was called to cannulate this because my colleague had tried it for some time, and this is I'm just showing you the direction of the bile duct takes and direction the pancreatic duct takes. And here we use a device which is soft. So we are preloading our papillotome with 032 permo guide wire, which is angled. so that it has angled guide wire gives you more uplift. So we are gaining our first entry into the, I told you 11 o'clock to 1 o'clock. Only thing we are preventing is too much of, bending of the bile duct, which is already in intramural, has no muscle here, and this gets kinked. So now we have entered the bile duct. You can see the bile coming in. So you have to be gentle. You have to go in with a soft device so that you do not kink the bile duct much. This is type 2 papilla, which I showed you, a very small opening. And here, again, you use a guide wire to cannulate, because it is big, it is smaller than the tip of the papilla, tip of the papillotome. So you go with the 032 guide wire, which is angled, thermo guide wire, which is very soft and hydrophilic, and you watch under fluoroscopy where you're going, target at 11 to 1 o'clock without distorting the CVD, and then you can succeed. Then I'll talk about double guide wire technique. Pre-cut and pancreatic guide wire techniques are appropriate when cannulation is difficult. If you have these two techniques which I told you have not succeeded going with a thermo guide wire, then you are left with the option of either using pre-cut or double guide wire technique or stent into the pancreatic. If guide wire has entered the PD, then we will prefer a double guide wire technique or a stent there. There are 3 randomized controlled trials, and pooled cannulation success rate was 60%. But see, there is significant incidence of post-ERCP pancreatitis. So be prepared for that, because only putting in a guide wire in the pancreatic duct will not save you, will make you successful, but you have to stent it after you have completed the procedure, because otherwise you will end up with pancreatitis. And placing 5 French PD stent is recommended in such situations. Many people will place 5 French PD stent first and not keep the guide wire for too long in the PD, because you may not be able to handle it well and may cause pancreatitis. And this is how this technique is, that you have put in a guide wire into the PD. The advantage is that this guide wire then lowers the pancreatic ductal orifice and opens up the bile duct orifice for you to enter. Let me show you an example. This is an intradiverticular papilla, and not very easy to cannulate. You do not know which, I showed you very beautifully that this is the CBD and this is the PD, but here you cannot see that, because it goes like this and then it turns and then takes upward course, so there is a distortion of the anatomy. So here what we do is, many times we try to go into whichever duct we can go, and here you see the direction is typical of pancreatic duct. I have elevated and I am going straight, it will be PD. There is no question about this. So I have entered the PD, we will confirm it on floor. Yes, I have entered the PD. Now I don't do anything. I keep the guide wire there, and then we, mostly we would have put in a stent and then done the pre-cut over this. Why I didn't do a pre-cut with that? Because it is intradiverticular. I wanted the wire to be used to keep my papilla outside the diverticulum. So now I have been able to go inside the bile duct after a small pre-cut, and you can see the guide wire is in the PD, and this is how the angle of the guide wires is, that you can see the direction it takes. The other is you secure the pancreatic duct with a stent and then do a needle knife over it. This is an example of that you go into the PD, you put in a guide wire, you put in a stent. I think the audiovisual team is very generous. They have not put in any timer now for us. So now you put in a stent. The mistake here is that this is a 7 French stent. It should have been 5 French stent. And then you do a needle knife over it in the direction of the bile duct, which is, again, I keep on insisting, 11 to 1 o'clock. So you open the, pre-cut is not like a single slash thing. You cut the mucosa, you cut the submucosa, then you open up the sheath of the common bile duct, and see this salmon pink mucosa, this is the opening of the bile duct, and this tells you this is a bile duct, and you can enter that and proceed with your therapeutic procedure. Then coming to the pre-cut papillotomy, it is preferred next time if standard cannulation fails. And meta-analysis, one of the meta-analysis published in 2015 showed that pre-cut versus continued cannulation, it has higher success rate, lower post-ERCP pancreatitis rate. Very interesting study which compared the pre-cut at 0 minute, 5 minutes and 10 minutes and showed that if you do it too early, your pancreatitis rates is much higher than the standard cannulation. But if you have already reached 10 minutes, then of course the pre-cut is superior to continued cannulation. So must learn the technique of pre-cut, if you are going to pursue ERCP as a carrier. And this is an example how the pre-cut should be done. You take out small bit of wire in a sphincterotome, which is needle knife. You don't take out too much of wire. I'm just taking out 3 millimeter or 4 millimeter wire, not more than that. I'm slicing out, entering the ampullary orifice, slicing out the roof, and then I'm carefully seeing where I am, and you can again see that there's salmon pink because I was there on this corner, and we go with the papillodome and or a guide wire, and you can enter that. There are situations like this where there is a periampullary carcinoma that is making the intraduodenal CVD bulge out like this, almost a cystic bulge. You try to cannulate through the regular orifice. It's difficult because you have to lift the tumor, and then again the problem is that you don't want to cut through the tumor, and many times you may not be going in the right axis. So what you do is that you do a fistulotomy over this grossly dilated bile duct, which is so easy and gives you an access into the bile duct very easily, and you can do your therapeutic procedure. This procedure I'm showing for people not to pursue unless you are very accurate with the with the amount of papillodome which you put in. This is called that you are going into the PD, you cut the septum between the pancreatic duct and the bile duct while keeping your sphincterotome in the pancreatic duct. It has the highest incidence of pancreatitis, and you must put in a pancreatic stent after this. This is what happens, that you are in the pancreatic duct, you cut from here, and then you open up the bile duct. But let me tell you, please, this is shown for you not to be done. Try not to do it. And if you see the video, you can realize that even I used to do it when I didn't have that many gray hair, and I have learnt after that a lot, and I don't do it today. You can see that now I have done the septotomy, and the bile duct has come to the right side, and instead of being on the left of the view, and now I'm cannulating the bile duct, which is there to be cannulated, but prevent post-ERCP pancreatitis, because that is very important. So when ERCP fails, we saw when a cannulation was not failed, we told you what to do, but when ERCP fails, PTBD was our conventional approach. It had a success rate of 87 to 100%. But today, as endoscopists, we would not like to send our patients to an interventional radiologist, but we do it ourselves. So you can do EUS guided biliary drainage, EUS BD, various forms are available, either hepaticogastrostomy, hepaticoduodenoscopy, or a combined ERCP US procedure. And this is a meta-analysis of 9 studies with nearly 500 patients, and there was no difference in EUSBD versus PTBD in technical success. And EUSBD had better clinical success, lower adverse events, lower reintervention, similar length of stay, more cost effective. So today we use ESBD when ERCP fails. So thank you very much. This is just a algorithm of how we proceed, but I think it's more important to remember that learn the techniques which I have told you, and keep patient safety in mind. Thank you.
Very interesting, and sir, you touched the basics, and it was very enlightening. We can have a few questions. Yes, Dr. Agarwal.
See, first thing, which whoever says that, has he ever tried to put in a clip through a side view endoscope? Let me tell you, putting in a taking out the, clipping device through the side view endoscope itself is a nightmare, and you cannot be accurate. So those are fancy things. Somebody does it once doesn't mean that what I'm talking is what you should be doing regularly. Yeah. Yeah.
Dr. Shubhra, yes.
Sir, very nice talk. First, I want to ask about putting the PD stent. So, do you remove the flap of the stent when you put it?
So PD stent we put in the pancreatic duct to prevent post-ERCP pancreatitis. There are studies to show that many times people used to remove it at the end of the day, that after 5-6 hours they used to remove it so that patient doesn't have to come back again. There's one study available which showed that same day removal of the PD stent versus removal after 72 hours. That showed that the PEP is prevented only if you remove it after 72 hours. So we should be removing it after 72 hours. So there is a strategy to maximize the chance of that stent falling out on its own. For that, we remove the flaps which are going inside, and also we use the 5 French stent for that only. There were earlier 4 French stents, but there the guide wire which was required was very difficult to manage, 0.18 guide wire, which was a useless guide wire. So that's why we put in 5 French stent.
And sir, what do you think about upfront rendezvous procedure as compared to a needle knife?
Let me tell you, there are studies coming where the failed DRCP or even upfront rendezvous of EUS guided versus continued procedure, that there is no inferiority. But let me tell you, when we see these studies, we should remember that the person who did rendezvous was the expert in that field. It is not a wide spectrum analysis of people in the field. So I will not suggest that today.
And so finally, sir, do you think needle knife should be taught to the residents during their
See,
DM
ERCP is not a technique which will be taught in the during your DM residency, because this is a specialized procedure like advanced EUS, ERCP. These are all meant to be, meant to be trained for 1 year after their post-DM or DNB training. But yes, the basics of it, they should have learned about the side view endoscope use and the cannulation techniques.
Thank you, sir.
Well, I told you, safer is to put in a stent because not many people can handle 2 wires. But this was a typical situation where the papilla was inside the diverticulum. I wanted a wire, if you see that I'm not using thermo this time, I'm using a glide wire which is stiffer, so that I can pull the papilla out and give me, it was used as a retractor also, so that I can go inside the bile duct and maneuver it well. So that was a deliberate decision taken of not putting in a, otherwise the standard should be put in a 5 French stent without internal flaps, preferably single pigtail, so that it migrates out, doesn't have the chance of migrating in, and then proceeding with your needle knife or attempt at cannulation.
Thank you very much, sir.
Thank you. Yes, sir.
And this is the time to felicitate the healing hands of Dr. Randhir Sood, and I request the moderators and the chairpersons to do it jointly. Thank you for this incredible presentation. Excellence in each slide. Thank you, sir, for being here with us. The applause should be louder. Thank you.
Taking it from Shubhra is the biggest player.
Thank you, sir. I thank the chairpersons for their precious time. And now is the time to move to another presentation. And for that, I invite the chairpersons. And the chairpersons are Dr. Divya Singh, consultant gastroenterologist from Sultanpur, Dr. Anshuman Elhens, Assistant Professor, Department of GI Medicines, All India Institute of Medical Sciences, New Delhi. Dr. Sanjay Srivastav, Consultant GI Surgeon, Devi Shiv Hospital, Lucknow. And Dr. Dayaram Yadav, Consultant Gastroenterologist from Sahara Hospital, Lucknow. And I request the chairpersons to introduce Dr. Gaurav Chawla.
Next speaker is Dr. Gaurav Chawla. He is my colleague and CMC alumnus, presently Director, Kanpur Medical Center, and his constant endeavors have put Kanpur actually on GI endoscopy map of India. So Dr. Gaurav, he will be speaking on small bowel lesions.
At the outset, I would like to thank sir for the kind words. Thanks organizers Dr. Puneet and Dr. Rumta for the opportunity. So I have covered my topic on 4 aspects. Initially, I'll be talking about device-assisted endoscopies, then therapeutic procedures in small bowel, then upon intestinal angiodysplasias and role of capsule endoscopy. So device-assisted endoscopy at the outset should be done only in the presence of CO2 to be used, and patient should be well sedated. If we are using antegrade roach, GA should be given. If we are doing retrograde, then conscious sedation also can be. So which route to start? According to ESG, it recommends that if previous diagnostic investigations are available and if we know the lesion is in proximal jejunum, then antegrade can be done. But if lesion is distal ileum, then retrograde. So choice of insertion depends upon our previous workup. If we don't have a decent previous workup, then we can do antegrade first, should be the preferred choice. And if the patient is having a massive bleed, then also antegrade should be our initial choice, because lot of clots and blood will be encountered if we start with retrograde. And both should not be done in the same session, because yield of pant endoscopy whips are less if we do both in the same session. So first I will touch about motorized spiral endoscopy. So this was a unique scope, 168 centimeters long, with an electric motor applied here at the shaft of the scope. Then it had a oval tube which was 24 mm with a spirals attached to it. Then there was a foot pad through which we had we had forward and backward movement of these rotations, and this was a pressure gauge which used to tell how much pressure with that the pleating of bowel is happening, and it used to automatically stop when it reaches the maximum pleating. So this came into with Olympus made this in 2016. So currently in 2023, in June, this systematic review and meta-analysis came from AIG and PGI Chandigarh, 10 studies, 961 patients, 1,068 procedures, and technical success was 94%, and good diagnostic yield of 73.7%, which is the standard in endoscopies. Pant endoscopy rate, if we do combine, was 61%, and with antegrade alone, 21.9%, and major adverse event was only 1.9%. Then this is a famous motor CD trial where they compared motorized spiral endoscopy with single balloon endoscopy in suspected Crohn's disease from AIG, 125 patients, 62 and 63 in each group. Overall technical success, diagnostic yield and procedure time were not significantly different. But if we want to go to deeper small bowel, distal jejunum, proximal ileum, MSE scored over single balloon in higher depth of maximum insertion, higher depth to time ratio, and total endoscopy rates. And both modalities were safe, but minor adverse events were more common with motorized spiral endoscopy. This was a study of motorized spiral with double balloon endoscopy from Christopher Course group from Singapore, 31 motorized spiral, 62 double balloon. So there was no significant differences, technical success, diagnostic success, and therapeutic success between double balloon and motorized spiral endoscopy in a randomized trial. Adverse events, double balloon was very safe, one only, but some minor adverse was there in motorized spiral of 11 patients. But remember that 2 patients developed sustained deep lacerations in the proximal esophagus requiring hospitalization, and one developed ileal perforation also, which required a surgical repair. So there has been case reports of detachment of spiral fragment during antegrade motorized spiral endoscopy. This was a jejunal tumor. They were trying to cross the tumor, so part of the spiral fragment got attached here, and then they went with double balloon, catched it with snare, but they were not able to remove it. So then they left it and gave polyethylene glycol. Next day, they were found that it came in cecum. Then again, there was a disconnection of the spiral tube at 90 minutes into the procedure in one of the patients in which they were doing ERCP in altered anatomy, and so they inflated a CRE balloon inside this of 20 mm and then pulled it out. Again, patient developed lacerations in the esophagus, and required NG tube placement and hospitalization. This was a case report from AIG Parthapal. He encountered a small bowel transaction after parolar motorized spiroenteroscopy. So, in middle-aged 52-year gentleman, 24.5 BMI, obscure GI bleed, capsule showing a mid-small bowel erosions. So he placed a clip while withdrawing, and after withdrawing, he was not able to withdraw, and then sudden giveaway was sent. So when while withdrawal, he started going into the peritoneum, and he could see the liver also. So then further withdrawal show a rent which was there, then he was taken for laparotomy, and there was a rent in the mid-ileum, complete transaction was there, and there was a giving of, at this point, the spiral fragments has given up. So in July, we got an urgent field notice. Everyone, pan-India, pan-world, there was an urgent field notice, and it was withdrawal from the market. Being in European, the spiral tube got stuck in the esophagus of few patients, and they could not take out the spiral tube. So patient was subjected to thoracotomies, and still patient succumbed. So in July 2023, it was withdrawal from the world market, motorized spiral. So currently, we have two modalities. One device was spiral, which was used pleating. Now second device is balloon. Balloon, what it does, it anchors the small bowel, and over that pleating happens and it straightens the loop, and we are able to progress. So we have a single balloon enteroscopy where one balloon which are attached to the over tube, and then a double balloon enteroscopy. Double balloon has been there since past 2 decades by Yamamoto, 2001. Single balloon is developed by Olympus in 2007. So we have various scope sizes. Usually standard enteroscopy scopes are 200 centimeter. Some shorter scopes are also made by Fujinon for the sake of convenience of doing ERCP in altered anatomy. You should know the channel diameters, because some channel diameters are not less than 3.2, so which will be having difficulty in doing the works. Some are slightly thinner scope diameter, 7.5 mm. So you should know the scope diameters. The thinner scopes were made because some patients have altered anatomy, adhesions, small bowel diameters. To complete the procedures, to completely do pan-procedure, these smaller scopes were made. Now, technique involves a series of push and pull movements known as advancement cycles, through which one balloon is inflated, then again deflated, again inflated, and this leads to forward movement of scope and pleating of bowel over the oval tube. With proper training experience, we can go up to 240 to 3 centimeter. So use of fluoroscopy, sometimes we have to use ancillary procedures. You have to see the fluoroscopy. So you can see if you are getting a loop like this, which is a counterclockwise, concentric anti-clockwise looping, which is a favorable thing to happen here. And then you should try to control the scope tip with the left hand, both a big and small wheel, and with the right hand you should be able to control the oval tube. So ESG recommends the use, do not recommend the routine use of fluoroscopy, but if you are in doubt where the learning, if you are in your learning process, if there is altered anatomy, you should use fluoroscopy also. Now, single balloon versus double balloon, people who have experienced, this is a systematic review and meta-analysis of 173 from Shanghai University. Single balloon had significantly higher diagnostic ratio than double balloon, and it took significantly less time for single balloon via the oral route. And in terms of the impact on diagnostic therapeutic course and complication route, it was same. Similar findings were there in one systematic review and meta-analysis from South Korea, where 65 procedures, 44 of single balloon, in 44 patients with 74 procedures and 69 patients with double balloon, along with 4 RCTs and 3 meta-analysis. So they also found that it was similar impact in terms of diagnostic therapeutic course and complication rate if a scopus is both experienced for single balloon as well as double balloon. This was a study from United States where they compared 146 double balloon with 510 single balloon. So no doubt deep scope insertion depth is possible with double balloon only, and low rate of repeat procedures. But higher is, if lesion is in proximal small bowel, higher we can go endoscopic homeostatic interventions can be done in a short procedure time with single balloon. So what are the therapeutic procedures in small volume? You should agree that whenever we are dealing with small volume, always there will be a problem of looping and unstable scope position. So device-assisted endoscopy should be the preferred option for investigation and therapeutic intervention before more invasive modalities are to be undertaken. And usually endoscopy, all endoscopic therapeutic procedures which you do in gastrocolon can be undertaken at the type of device-assisted endoscopy. And usually but we should keep in mind that all these procedures should be performed with additional safety measures which I will be discussing. And during all these procedures should be done usually the withdrawal phase of device-assisted endoscopy. So vascular lesions we frequently see about in small bowel. APC of vascular lesions can be done, but APC, we are burning the mucosa. So small bowel only has 3 mm of mucosa. So we have to inject saline so that there is a cushion created at the submucosa level and we are not able to cause a through and through perforation. Usually we should do a low voltage setting of 40 watts, flow rate also of 0.8 ml per minute. So these are the precautions. If we are doing endoscopic resection of mucosal lesions, so usually we inject large amount of saline, but here injection of large volume should be avoided, because if we inject large volume, our snares will have a difficulty in going. Small volume is usually small, so we should not inject large volume, just 3-4 ml is enough. And stalk should be resected close to the polyp head in small bowel, otherwise chance of perforation also may be there. Now, if you have encountered a strictures of small bowel, then what to do? So basically, we should have a thorough evaluation on the number of strictures, location of the strictures, characteristic of the stricture, and length of the strictures. All have important aspects. Short stricture less than 5 centimeter with no active ulcers at the site, straight strictures. These are the preferable strictures which can be managed endoscopically. Through the scope balloon of 18 to 20 mm also has been used, and usually fluoroscopy should be used in such settings. Then direct percutaneous endoscopic jejunostomy tube placements also have been done in patients with altered anatomy with malnutrition, and usually same precautions of adequate transillumination and distal intention, and use of a 21 gauge Seeker needle should be used. Then ERCP in surgical altered anatomy is a topic in itself, but usually we should know the anatomy very well in such cases. Here if you see a head J site which was cannulated with straight biliary catheter, and then dilation was done, and then stent was placed, stone was removed. So in such cases anatomy should be known. We should choose the right scope where all accessories are going. We should know our accessories well. Sometimes we use an inverted sphincterotome where instead of upward in sphincterotome direction it's inverted down, and anatomical should be there. So third part on intestinal angiodysplasias. So in angiodysplasias encompasses a wide variety of terms. Some literature has used angioectasias, Dolichois lesion, arteriovenous malformations. So all that has been covered into intestinal angiodysplasias broadly. So this classification should be used whenever we are doing angiodysplasia, Yana-Yamamoto classification, which is very simple and effective. If it's a punctate arrhythmia less than 1 centimeter without oozing, if it's a patchy arrhythmia, or if there is a pulsatile bleeding less than 1 mm, or pulsatile bleed with a component of venous, or there is a pulsatile red protrusion with surrounding venous dilatation. Why this classification is important? Because it will give us the presence of arterial component, and which will additionally give what optimal treatment to be done. It can affect the patient's prognosis. So if you see a video capsule endoscopy, here is a lesion there, and with device assisted we are going to the small bowel. In this APC is just enough because it was type 1B lesion. Whereas if you see Dolichois lesion, pulsatile lesion in small bowel, dual therapy is recommended. Out of that, one mechanical therapy. So here APC was done and clips were put. So whenever we do pulsatile lesion in small bowel, dual therapy should be recommended. So here a polypoid lesion on video capsule endoscopy, which was type 4 Yamamoto. So it was arteriovenous malformations are prone for recurrence. This was a large lesion which was surgically resected, and it found to be it. Some role of pharmacological treatment was also there. Hormonal therapy is not shown to be effective. Thalidomide is effective in randomized control trials, long term up to 39 months, but it has side effects. Again, somatostatin alone also has shown to have a good pooled odd ratio of 14.5 for bleeding cessation. Similarly, long-acting release of octreotide has also been shown to be good and cost-effective. and lanreotide. So all these modalities can be used because some patients will have recurrence of bleeding and some may not be because of old age and multiple comorbidities may not be fit for endoscopic therapy. So this I just, for obscure GI bleed, I wanted to give you one guidelines. This is a Japanese guidelines where they initially do for all obscure GI CT scans from chest to pelvis. If they found the abnormal findings, they will directly go to balloon-assisted endoscopy and then take a call of what to do. If there is no abnormal findings on scans, then they will do a capsule endoscopy and then decide. Then if it's a massive bleed, patient is unstable, they may go for angiography. In some cases, they may go for Meckel's also. So this guidelines differs from the guidelines which Europeans follow. Whether obscure or occult, they will do capsule endoscopy first. They will document the lesion and then only device-assisted endoscopy will be done. If there is no, then they will follow up the lesion and consider capsule device later or CT later. So this was the difference. Coming to the last part, in capsule endoscopy came to market at the dawn of the millennium. It was developed by Israeli scientist and a British gastroenterologist, Swain. That time capsules were lasted for 8 hours only, but today we have innovative capsules with long battery life, wider angle of view, faster adaptable frame rate, improved resolutions, and we have capsules which can take panoramic images. It has a diagnostic yield of 60 to 70% in all literature on all studies. The problem with capsule is that so many images are there and who will see the image, and that is the problem. So ESG recommends that it should be read at a maximum speed of only 10 frames per second in a single view mode. If we are using multiple view modes, maximum speed of 20 frames per second are also alternatives. And even in proximal small bowel, we should slow down the frame rate. Some automated fast reading softwares are also being developed, like suspected blood indicator algorithm. It has a sensitivity for detection of active bleed is to the tune of 99%, but if it is not bleeding, the patient has a bleeding lesion, sensitivity and specificity decreases to 55 and 58%. Then there is a quick view algorithm by Medtronic, which selects 10% of the most relevant images on capsule endoscopy and reduces the time to 11.67. But again, high rates of discordant with manual reading of 28. Then there is another algorithm where they reduces by 50% the reading time of small bowel capsule endoscopy. But again, sensitivity is only 78%. So we can take help of this fast reading softwares, but this should never be replaced the conventional reading, manual reading by an expert endoscopist. Now to solve this problem, AI is coming in capsule endoscopy also. So machine has been taught what looks like a angioectasia, what looks like a tumor, what looks like a erosion. So machine has been taught and made to learn. So there is a neural network algorithm for the detection of angioectasia. Just I'll be finishing in a minute. So neural network algorithm for the detection of GI angioectasia doing so. This is an annotated image, convoluted image, and this is the final machine knows that this is the angioectasia. And study has shown it is a very good sensitivity of 100%, specificity of 96% with 96% of positive predictive value and 100% of negative predictive value. And reproducibility was optimal, reading process was just 39 minutes. So it has a very high diagnostic profile, and future studies are being doing with AI in capsule endoscopy. Smart pill is also available, which can give guide to the assessment of regional and whole gut transit times. It is FDA approved. It measures the temperature, pH, and pressure while traveling through the GI unit until the existing body through the MS. So we can transit of gastric emptying, small bowel transit, colonic transit, and whole gut transit can be. To summarize, device-assisted endoscopy this year, motorized valve suddenly withdrawn from the market after 7 years of clinical utility. The balloon endoscopy remains and will remain the mainstay or safe and effective modalities, but it is time-consuming. And all therapeutic interventions can be undertaken in small bowel, but we should take proper precautions and proper evaluations. Most intestinal angiodysplasias can be managed endoscopically, but recurrent cases may need pharmacotherapy. And many new developments are happening in the field of capsule endoscopy. So next decade we may have AI-generated capsules, robotics in capsules, and so better capsule, better diagnosis and therapeutics may be possible. So thank you and invite you for my conference on 4th and 5th November.
A very exhaustive talk, Dr. Gaurav. Any questions? think. So if there are no questions, we'll felicitate you. Please come.
Thanks for the wonderful deliberation, Dr. Chawla, and I request the moderators and chairpersons to felicitate Dr. Chawla jointly. Thank you. I thank the chairpersons on stage. Thank you for joining us on the dais for this session. And moving on to our next session. And for that, we have chairpersons, and I am grateful for them to be on stage. I invite Dr. Jayant Ghosh, consultant gastroenterologist from Ranchi, Dr. Anurag Tiwari, assistant professor, Department of GE Medicine, Banaras Hindu University, Varanasi, Dr. Santosh Yadav, senior consultant gastroenterologist from Banaras Hindu University, Varanasi, and Dr. M.M. Patel, professor, Department of Medicine, King George's Medical University, Lucknow. And the speaker is Dr. Rohit Gupta, and I request the chairperson, moderators to introduce him.
So we invite Dr. Rohit Gupta, an alumnus of SGPGI from Prayagraj. He is a very keen, ardent and innovative endoscopist, and he will be speaking on some few tips and tricks in therapeutic endoscopy. Dr. Rohit Gupta, please.
To then Praveer, I will be giving you a share of some cases which I have done over the past few years. Sorry. This is a patient, 28-year-old female with choledocholythiasis and cholangitis. Wire-guided biliary access failed, and there was repeated biliary cannulation. So, once we were entering the PD, we did a needle knife. Can we have the pointer? The pointer. So now we have access and the double guide wire technique. I think that putting a stent only after I finish my procedure, because you can't get into the CBD. You can't get into the CBD once you put in a stent. So you do your procedure and then put in a PD stent. So what are the tips and tricks? Dr. Sood has already told you. You can use a double wire technique. You can do a needle knife. As in this case, you can do a pancreatic sphincterotomy, which is a little dangerous. And if there's a good bulge, you can do a fistulotomy. So second case is 36-year-old female with choledocholythiasis, cholangitis. Post-ER CBD clearance was done and CBD stenting was done. Unfortunately, the CBD stent migrated, and stent removal was tried outside another city, but could not be done. We also tried twice to remove the stent. Here you can see the stent is not seen. Sorry. Can we start the video? Yeah. So what we did is we did a sphincteroplasty, tried all the tricks in the trade, but failed. We used a basket, balloon, everything. We failed to remove the double pigtail stent. So what we did is went in with the laser, and our plan was to cut the stent into two and then use a wire. But after cutting, luckily, after cutting the stent into two, the axis changed and we could deliver the two pieces easily with the help of a foreign body forceps. This is the lower part of the stent which we could remove. And then we hold the proximal part with a Dormer basket, last few shreds that we could hold on. This is the part of the stent which we removed. This is a simple case where the pancreatic stent had migrated. You put in a spy scope and just put a spy bite forceps and remove the pancreatic stent easily. We tried the conventional methods but it failed. So we tried this and we could do it simply. So if you have a laser and you have you can do a cholangioscopy or a pancreatoscopy, that may become handy if the conventional techniques fail. So this is a patient, a difficult patient, 32-year-old male with the pancreas division and pancreatolithiasis, single stone, referred for endotherapy. So if you can see this is the major papilla and this is the minor papilla. Bile is coming out from the major papilla. So we went in with the regular sphincterotome. Easily we could cannulate the minor papilla. This is the pancreatogram, large stone. We did a minor papilla sphincterotomy. And then we did a sphincteroplasty with the regular biliary balloon. We tried balloon extraction, but it did not work. So we would put in a spyglass into the pancreatic duct. We could switch the stone. We blasted it with the laser partially. This is the spy laser which is blasting it, and then we tried balloon extraction. So we are fearful of baskets, so we always use a balloon, and we could remove the stone. So in large PD stones, laser lithotripsy can be done, and with experience you can do it in pancreas division as well. This is another interesting case, post-cholecystectomy bile duct injury and under large bile leak. You can see the drain and a large bile leak. We went in, we put in a pigtail stent into the collection. Then we, after 2 or 3 weeks, we asked our intervention radiology colleague to, we couldn't enter this part of the CBD, and so we put in a PTBD catheter, the IR colleague, and then on the next sitting, the drain is here. We passed in a guide wire, you can see the guide wire, and the intervention radiologist put in his vascular snare, and he could catch this wire, took it out from the trap, and then we could railroad, do a rendezvous procedure and put in a stent here. The bile leak stopped. Unfortunately, this patient had CA larynx and is undergoing treatment for the same. So in difficult cases, you should have all the help you need, surgeons, IR colleagues. That helps a lot. Another case, post-cholecystectomy with choledocholectasis and cystic duct stone remaining. I am very fond of doing a sphincteroplasty because that saves your balloon and eases your comfort level. This is a balloon sphincteroplasty, and then the multiple stones from the CVD could be removed easily. But there was another stone which was there in the cystic duct. So we went in with a spyglass and fragmented the stone easily. and took out the stone, and the patient was free of symptoms. So you can use a cholangioscope if you have, and laser lithotripsy, and you can salvage many such patients. This is another rare patient with situs inversus and choledocholithiasis. In this, everything is reverse, even from entering to exit. See, I am cutting in at the 1 o'clock position because the anatomy is different, and you almost always land up in a long position. I have done 2 or 3 cases now, and what we have learned is that long position can be maintained if you do a sphinctoplasty, and you could retrieve the stone as well. Sphinctoplasty is always helpful in all the 3 of our cases, and we are careful to keep the guide wire in situ, because if you are out, then second cannulation would be difficult. Another patient with buried papilla in a large periampullary diverticulum, the cannulation failed. So we did a pre-cut sphincterotomy over the septum. This is the diverticulum. You have to be in the position, and mind you, I think this is relatively safe because you are not going either towards other side. You are in the center. We couldn't cannulate in the first go. Second go, it was again going into the PD, so we put in a pancreatic stent, and probably in the third attempt, we could enter the CVD, and we could do a sphinctoplasty and remove the stent. And the patient was elderly, we could save him from surgery. So we have resorted to pre-cut in periampullary diverticulum. I think we've never had a complication in diverticulum. Otherwise, in routine ERCP, you have pancreatitis, you have perforations occasionally, but in pre-cut in periampullary diverticulum, I think is safe if done, if you have enough amount of experience. Other things that you can use is a foreign body forceps, and you can inject saline into the diverticula to make the papilla prominent. Another simple technique which I have learned is another simple technique, usually the cannulation is unsuccessful because your direction of the CVD is different. So the routine sphincterotomes usually don't work. You have a failed cannulation. So what we try, this is a regular sphincterotome, we are not able to enter into the CVD. We are failing to enter the CVD. So what we do is, we use a sphincterotome which is a rotatable sphincterotome. So you see, this is a rotatable sphincterotome, and now my technician is turning to the right, the sphincterotome is turning, and you can, now I am too right, so he'll just ease it to the left, and you will have a cannulation. So true tome or a rotatable sphincterotome also helps in a number of cases. So rotatable sphincterotome I have used when the lumen is towards the right or left and you are not getting axis, you try a rotable sphincterotome and it will help your cannulation. Even in the colon or in the stomach, you can do it. Another case, duodenal obstruction, periampullary carcinoma with cholangitis, elderly gentleman. We did gallbladder drainage from the stomach. This is a hot axial stent placed from the stomach, and you can see pus coming out. In the second sitting, we put in a double pigtail stent so that the hot axial does not bury into the gallbladder and cause perforation. So it was periampullary advanced CA, and This is the stent in the hepatic duct. So when the road is difficult, think out of the box, and most of the times you will succeed. Another patient bleeding during necrosectomy. This is a patient after necrosectomy. We did a necrosectomy, and after necrosectomy it started to bleed. So we tried one glue injection. This is the first glue injection, this is the second glue injection. And we tried that, but it continued to bleed slowly. It was slow bleed, but it continued. So what we did is we put in a clip and the bleeding stopped. Otherwise, there was good healthy granulation tissue. We could remove the stent after 2 weeks. Another case which I wanted to share with you is abscess in the caudate lobe. In this patient, there was a vessel going anteriorly and we could not do it via ultrasound. So what we tried is easily we went into with an eoscope and we found that it is very superficial and we can do it easily. So this is the caudate lobe abscess. We punctured it, aspirated pus, dilated the tract with a 7.5 cystotome, and then we could place in a 7 French stent and the patient improved dramatically. So when an abdominal, transabdominal ultrasound guided drainage is unsuccessful, you can try this. My friend Dr. Sharad Chandra from Jhansi has done around 30 cases now, and he is almost successful every time. I'm not in a place like you all, big institutions. I have a very small clinic, and most of the procedures can be done. I have failures, I have complications, but I think for the youngsters, there is light at the end of the tunnel. You can try it. Most of the times you will succeed. You will have complications as everybody has. But in the end, you can try and achieve success. Thank you.
Thank you, Dr. Rohit. Yes, Dr. Samir has some hand.
Yeah. Yes, agreed. No, you can always remove the stent, the ENBD. That is also a good suggestion, and I think Dr. Sharad has done that also in his 30 cases.
Dr. Sharad actually always gives us an ENPD in such cases.
Yeah.
And at the end of the day, he just then puts in the stomach to let it drain and finally.
That's also a good technique. Thank you.
And like broken stents create a lot of problem, like a few ERCPs we did during COVID, lost for follow-up, and then finally they turned sort of maybe 1 or 2 years later. So how do you handle those broken pieces of stents? Sometimes it's very difficult to get them out.
No, I think I've done plenty of cases where the stents have been left by me or somebody else for 5 years, 10 years. And what happens is a stentolith appears, and the stentolith is quite big. In these cases, what I do is try first, always, I do a sphincteroplasty, because otherwise you won't be able to remove it.
Yeah.
Remove the stent, and in majority of cases, I say 80-90% of cases, if you do a sphincteroplasty, the stentolith is very soft. It is not like a hard stone. And you can, you take time, you take around 45 minutes, 1 hour, and then after sphincteroplasty, if you do a balloon sweep,
That's
plenty
cleared.
of muck comes out and you can clear the CBD very easily. It's not a problem.
Okay.
It is a common problem, and I think most of the cases, except when the stone is very hard, I think we can manage. Yes, Amit. No, I think you are right, absolutely right. This is previous patients, say 5-6 years back, and because I had burned my fingers, injecting glue into this, you can perforate, but usually it's a pneumoperitoneum, you can salvage it without surgery. Initial, first patient maybe the surgery was done. Second time my surgeon said the abdomen is soft, if you release the air, you put in a catheter, you can release the air and mostly it heals, but you're correct. I think clips would be a better choice than injecting glue. Yeah. Yes, yes. There is usually a thin wall and you can perforate also.
You can have aneurysm and whatnot.
Yeah.
Thank you, sir. It's time to honor our speaker, sir. Please, I request the chairpersons and moderators to do the honors, please. Sir, please. And with this, it's time to refuel ourselves. Faculty and delegates are requested to move to first floor, Roca restaurant for their lunch. Enjoy your lunch and will join us in 30 minutes. Thank you. Thank you. Thank you, sir. Welcome back after a tasty lunch. We all are recharged and refueled. Let's go back to our work. And we are proceeding towards the debate session. And for that, I am honored to invite most esteemed chairpersons on stage, Dr. Anil Kumar Rastogi, Dr. Ram Pratap Singh, Dr. B.S. Bhandari, and Dr. Kumar Abhishek. Please join us on stage. The topic for the debate is asymptomatic gallstone. Should all be offered surgery? And for this, for the motion, I invite Dr. Rajneesh K. Singh and I request the chairpersons to brief about him.
Is there a computer? For isko lagana. What do you do?
Dr. Rajneesh Kumar Singh, he is a professor in Department of Surgical Gastroenterology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow.
Computer. Connect करना है बस. My apologies. लगेगा तो चलेगा. No. Good afternoon. I hope the food is catching up with you. There's not much to offer in the talk at least. But I'm very grateful, my senior colleagues, Dr. Abhijit, Anand, Anshuman, and a couple of other surgeons. Koi to hai mere liye? Okay, great. Right. So that's how you have a surgeon looking at you when you have a surgeon talking to a gastroenterology audience, because you have to agree to whatever the democracy says. But Sunny told me no more of this, you have to speak for the motion, so I will go for the motion then. Bottom line, it seems to me that when you talk about asymptomatic gallstones, whatever the controversies in the textbook and over the years and decades information, bottom line seems to be this: wait for them to develop symptoms, operate. This seems to be the running theme for most recommendations for asymptomatic gallstones who present to us, at least in the textbook. So then the next immediate question is, when a patient is sitting before you without any symptoms, can you predict symptoms in this patient? So then you start looking at a list of factors, again coming from the textbook, which may be predictive symptoms, and that's where the high risk features and so on and so forth come into being. Small list, actually the list is much longer. I've just put a few examples of what comes to 4. And there are a few factors where there will be no argument. Porcelain gallbladder, polyps, and so on and so forth. There will be no argument that we should operate, symptoms or no symptoms. The others are where the problem starts. Size, stones, number, composition, patient being 25-year-old versus 75-year-old, diabetic, has undergone kidney transplantation. That's where the literature becomes really muddled. And that's where this debate starts. Should you operate? Should you not operate? No symptoms. Let's just take the last parameter, because the rest of them, it seems that over 100 years we are not going to figure it out. So there's an article in favor of it, and a couple of years you have an article against it. So size 3 centimeters, 2.5 centimeters, still absolutely no agreement. But the last point plays a big role when the patient comes before you. So let's take that to start with. It seems that symptoms do develop in direct relation with time. The relationship is not linear, but it's definitely there. Meaning to say, the longer you live with a gallstone, the more likelihood is that you will develop symptoms. The corollary is, the younger the patient,
the more likelihood at some point in time in life she or he will develop symptoms. I'm just trying to put some provocative kind of statement before you. I have no answers, to be very honest with you. And I have confessed this to Samir also. These are the questions which arise before you in a outpatient, which you also have to answer to the patient without having any background literature favoring or against you. So longer you live, more likely you will have gallstones. So what is the natural history? There are several studies. The Gracie study has been the most quoted study, and we often quote that to our patients when we want to support symptoms or not support symptoms, depending on which side of the spectrum you're lying. Broadly, over 15 years, patients followed up, possibility of developing symptoms about 15 to 20%. Problem is, which is the 15% you can never predict. So the patient before you will be the 15% or the 85% you can never say. But nevertheless, this is the data before us. Maybe they have missed a couple of studies because this is a little old. One thing is common in all these studies, and that is none of them exceed 15 to 20 years. Which means that when a patient is destined to live beyond 15 years, we have no information. What will happen to that patient? Broadly, taking the same line on, duration predicts development of symptoms. This is a fact. There is absolutely no argument about it. What you could debate is whether the relationship is linear or it is logarithmic or some kind of a hyperbola of it. So when we take this as a predictive factor, then a patient who is 30-year-old sitting with us in the outpatients, no symptoms, becomes easy. You have life expectancy today in India is 70 years, 70.4 I think this year. So 30-year-old has 40 years to live. So it's quite easy to predict. Okay, you have 40 years to live, I'll advise surgery for you, taking that parameter in mind. The problem is what happens at 40, and what happens at 50, and so on and so forth. That's where the muddle starts. That's where literature fails us completely. And this factor also then goes down then you start realizing, let me advise them to all of them. What's the problem? If I can operate safely. That's the bottom line with the surgeon works. And the additional factor is that every year, last decade, we have added about 3 years to life, at least in India. So it was around 67 approximately, 10 years back, today is 70. And it will probably increase more because in the UK or US, it is nearing 80 now. So it's reasonable to suggest that asymptomatic gallstones should be offered surgery if the expectancy is long. The problem is we can't define long, and that's where problem starts. And so I leave that thought to you as to what you define as long in your clinic to your patient. The other factor which patient comes to you often with is, I have stones, will I develop cancer? Please operate me. That's the next consideration which comes before you. If you say that you are already 40 or 50 or whatever, so life expectancy is another 10 years, 20 years, I don't want to operate you. So next question immediately popped up to you is, will I develop cancer? Please operate me. That's the current fact statement of literature today. Pick up the gastroenterology textbook or the surgical textbook. That statement stands. It's uneconomical, not viable, so prophylactic cholecystectomy may be considered only in high incidence regions. Let's go to the data. What is high incidence? Is it worthwhile to prevent CGB by prophylactic cholecystectomy in those regions? There are two ways to do things. You take any country which is high incidence. Today we have Chile as a prime example. So you can offer it to all asymptomatic gallstones, or you can pick up some subsets of patients, females for example, more than 40 for example, and operate those patients. This has been a subject of some publications and very interesting publications. I quote one. 3 strategies were studied. There was one which offered universal screening to all people in a city or a region and offered cholecystectomy to all those who had gallstones. The other, they picked up stones which are large, more than 3 centimeters, and offered cholecystectomy to them. The third, picked up only a select subgroup of obese, certain females where they had stones on ultrasound screening, asymptomatic, offered cholecystectomy. And analyzed these parameters with respect to improvement in cancer-related deaths and cost. And this was the decision analysis model they came up with. It seemed that operating all gallstones was a much better option. I'm quoting this because it favors my part of the talk. But the other part seems reasonable. But when you start looking at the cost analysis, the expectancy of life increase, This is a high incidence region. It seems that in that area, that made sense. But the Western philosophy and the textbook philosophy today is still the same. To prevent one CAGB, you need to operate more than 100 asymptomatic gallstones. So books say no cholecystectomy, at least not on the face of it. So where are we then? Are we in the region of Chile or are we in the region of UK, US and so on and so forth, which recommend no cholecystectomy? This is just a bar chart telling you incidence per 100,000 population. This is Europe, that is Asia, and that is Americas, including the South Americas. Where are we? This is where we are. Since Chile is not there in the chart, so Ecuador is the nearest country which also has a high incidence region. I picked that up. We are as high as that region. So in our parlance, to say that we follow the textbook doesn't make sense. Because it seems that we are a fairly high incidence. Numbers, we are almost 20 times or 10 times more than what the UK or US population experiences. Color charts, we are the red region. North India, that's where we're sitting. We are the bluest, the highest region. So it still makes sense. You can't wish that away. You can't take that fact that, okay, I can only prevent 1 out of 100, why operate? So let's reduce the risk. What would be acceptable to you? 80 for one, 70 for one, 60 for one. Again, seems absurd. Where do you stop? No answer really. I'm leaving with more questions than answers. It's a dismal disease. Broadly, my department, we've operated almost 2,000 in the last 20 years, 25 years. Operated means resected. We're not talking about the bypasses, we're not talking about the metastatics, the stentings and so on and so forth. 5-year survival, pathetic. And those who gone before me in the department, those who are coming after me in my department, none of them contest this figure. Because we can count on our fingertips the number of people we have surviving of CAGB, locally advanced, who were resected in our department. And this is a massive experience. Most of those patients are incidental carcinoma gallbladders. Alarming? Yes, very alarming. Why is it alarming? This means that if you have CAGB, then you need to pick it up very, very early. For those who say that we'll screen for carcinoma gallbladder and operate when it appears, that's the problem. You can't pick it up in early stages. So then it makes sense that expectant management is a problem. Because how do you follow this patient up for that parameter, for CAGB? You don't know the frequency with which you follow up. You don't know what to look for on ultrasound to follow up and pick up carcinoma gallbladder, incidental carcinoma gallbladder. That's why it's incidental. You don't know if ultrasonography is good enough for you, and will the patient turn up after a couple of ultrasounds back to you. So you fall flat when you say, I'll selectively screen these patients and then operate. Again, now economic implications of a huge state, Uttar Pradesh, patient coming to you from far away. He doesn't have a good ultrasonologist in his own region. So screening means he has to come to you every time. The other reason why people abhor laparoscopic cholecystectomy is we are also, my department that is, and I'm sure that's the experience of my colleagues here, also some of the highest experienced peoples for managing bile duct injuries in the world. Not India, not Asia, the world. You count their figures and our figures, I think we'll probably total up more than the entire world. So that's a problem because you're offering a surgery which has a fairly high complication rate. It seems. The list of complications is not limited to this. It is probably 10 times this. You start picking up mine and my colleagues' complications together, the list will fill up 4 or 5 slides. Is it alarming? It is alarming. But here's a food for thought. Actually, it's easier in asymptomatic patients. Figment of my imagination? No. There's data. The conversion rates, the morbidities are far, far lower in asymptomatic gallstones. So when you look at complications of laparoscopic cholecystectomy, you can't generalize all of them. That's one I thought I'd leave you with. The other problem is when you wait, the patient's age advances. And that's a problem because data tells us the longer the patient has had gallstones, the more problematic the cholecystectomy. the mortality, and this is just a surrogate marker of difficulty, is higher for a higher age and lower for a lower age. So which means again, a 30-year-old, asymptomatic, outpatients, probably makes sense to offer a cholecystectomy. Right, so what does the West follow? This same parameter. They say that do expectant management and very selected patients, porcelain gallbladder, polyps, so on and so forth, operate them. Do they follow what they preach? Italian series, 11,000 patients, about 200 cholecystectomies done. Same publication, 40% asymptomatic. Conclusion of the publication, don't operate. Amazing what literature throws at you. And what you actually miss if you don't read a publication, and just read the abstract. So people who preach something and do something else are not the people I would want to follow. Economy, problem, because we don't have no data, and I can't say that it is something I can profess that, okay, we can do it cheaper or somebody else can do it cheaper. We'll have to generate data to say that we can't operate all of them. And we need to have a cost-benefit analysis in our society, in our region. Bottom line to my mind, I sometimes get into a debate and arguments with my own colleagues for this is, my first responsibility is to the patient who's sitting across me. Not to the society, not to the healthcare system, that is my second responsibility. So when I say that if I offer cholecystectomy all of them, who will bear the cost? I'm not bothered, I'm not a healthcare administrator, I'm the clinician. My responsibility is to answer questions of this patient and take care of this patient. I fully agree, for the healthcare administrator, this advice is a nightmare. But that's not what I'm debating. My debate is, should I offer a cholecystectomy? Patient's perspective. Patient sits before you, you say, sorry madam, textbook says no cholecystectomy for you. He says, he or she says, will this cause problems for me? You start quoting the data, Gracie's trial, 15 years, 15%. She says, should I undergo cholecystectomy? You already know answer for this. You can again quote the same data, 15 years, 15%. She says, will I follow the 15%? You have no answer really. Do you think I should get a CT scan done? You again start debating. It will add some money to a kitty, all right, but it will really not help the patient. Next question she asks you when you say that don't get operated is, okay, fine doctor, I'll follow your advice. When should I come back? You really have no answer to this question. Third question is, okay, I'll come back 3 months later. How many years? Again, we have no answers to these questions. So the bottom line, the patient at the end of the day, after you've hummed and hawed at the patient, she says, let's get the operation done and over with. So that is why patient's perspective is important. I'm talking about a given patient. It may not be the patient you are facing. So expectant management, 40-year-old multiparous woman, asymptomatic gallstones, a typical patient in the outpatients. We don't know which factors predict symptoms. This is all compilation of what we just said in the last few slides. We don't know how to follow up these patients. We don't know whether she'll follow for life. We don't know her lifetime risk of carcinoma gallbladder. And we don't know how to pick up early carcinoma gallbladder. And yet, broad smiles when we say, let's not operate these patients. So I rest my case here, sir. Just to conclude, huge gaps exist, and we are a high incidence region, not prudent to blindly follow the guidelines from the West. We need much more local data to actually go. Till that time, I think it should be a case per case decision rather than a blanket statement. Thank you. Samir, all yours.
So, against cholecystectomy, Professor Samir Mohindra is Department of Gastroenterology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. He will speak against cholecystectomy in asymptomatic gallbladder.
Good afternoon. First of all, I want to thank the organizers, Dr. Puneet, Dr. Sumit, for organizing such a great conference. I'm very happy with the content as well as the attendance. It's really amazing. And it has been because of the effort of these two people. It's always difficult to follow a surgeon who is good. But then debate is all about proving a point. So if we look at asymptomatic gallstones, the question is whether every patient needs surgery or some subset of those patients need surgery. So we need to discuss that. If we look at what are asymptomatic gallstones, asymptomatic gallstones means there are no symptoms associated with gallstone and it's biliary colic. Dyspeptic symptoms should not be taken as symptom of asymptomatic gallstones. Or there has been no associated complication. Complications include acute cholecystitis, chronic cholecystitis, acute biliary pancreatitis, cholangitis, CBD stones, and rarely gallstone ileus. Majority of the stones, more than 90% of gallbladder stones are asymptomatic. And autopsy studies have shown that more than 90% people who have asymptomatic gallstone die because of unrelated causes. And if you look at gallstone being responsible for death, it is less than 5%. So gallstones are very common, but majority of the patients don't get morbidity or mortality associated directly with gallstones. Gallstones are being discovered more frequently because of imaging. And with the advent of laparoscopic cholecystectomy in 1989, our threshold of offering that surgery to all gallstone patients has come down because better osmosis, easier recovery, faster recovery, less chances of complication like incisional hernia. Now there have been two sayings and both have been a century old and both have been by surgeons that there are no innocent gallstones. And number two, it is unfortunate that so few appreciate from what small causes diseases come. Basically they said that all gallstones have significant morbidity. And they were both surgeons. Now if you look at prevalence of gallstones, see there is a wide variation in the geographical distribution of how common are gallstones. India, approximately 10 to 20% patients, they can have approximately gallstones, and females have a higher incidence, which is 4 times as compared to males. And this is mainly the genetic belt which we are bothered about, where gallstones come into picture being a significant problem. Now, when we are trying to treat gallstones, we are not alleviating any chronic or debilitating condition. What we are trying to do is we are anticipating a problem will come and we are going to avoid it by doing a cholecystectomy in asymptomatic gallstones. But the problem is this problem may not arise at all. So why offer something which is very safe surgery but not absolutely safe? Should we offer to all of them? Now, there are 3 approaches of asymptomatic gallstones. We wait and watch. If symptom develop, we offer cholecystectomy. Or we do cholecystectomy in all as Chile, where any lady more than 30 years or any male more than 40 years is offered cholecystectomy. Or we offer cholecystectomy when the symptoms come or a complication arise. Now, whenever we think about a procedure or a therapy, we have to balance what is the natural history of that problem and what are the potential complications, how serious are those complications. And then on the other side, we have to balance with morbidity, mortality, and cost associated with that intervention. Now, when a patient comes to us, there are 4 questions we need to answer. Will they become symptomatic? Will they cause complications? Can it cause a life-threatening complication like gallbladder cancer, which in most of Dr. Reddy said, incurable, 5-year survival is less than 5%, curative surgery is less than 5%. And if the gallbladder has to be removed, when it has to be removed. So these are the questions which patient will ask you. Now, if you look at the natural history, Dr. Reddy has presented this, approximately 10% patients become symptomatic in 5 years, and approximately 20% become symptomatic in next 20 years. So what it means is basically 1/5 of the patient will become symptomatic over 15 to 20 years. If you look at complications are less than 5%, but I agree that the follow-up period has been only 15 years. This may not hold true when a lady comes 20-year-old with gallstones being picked up. This may not hold true because she has 40, 50 years to live. But approximately 1% patient will become symptomatic with gallstone, and approximate incidence of complications other than gallbladder cancer is less than 0.5% per annum. I'll not go into this. This is a recent article in Clinical Gastroenterology where the follow-up of 4.6 years, and they tried to find out factors which make asymptomatic stones symptomatic. For example, females have a higher chance, BMI more than 30, tobacco user, chronic hemolytic anemia, which is a very important indication of treating asymptomatic gallstones, multiple stones, large stones, and if there is a polyp, now you have to qualify which kind of polyp, and of course sludge. This is a retrospective study, Italian study, where they looked at almost 800 patients. What you need to put attention is the red group. 580 patients asymptomatic over 9 years, 80% were asymptomatic and 10% had mild symptoms. So 90% patients were asymptomatic over a period of 8 years. And whoever had a biliary colic, if you look at the right side, I'm sorry, the mild symptom had biliary colic. Approximately 80% patients remained asymptomatic or had mild symptoms. So asymptomatic gallstone, 80% remained asymptomatic over 8 years. Mild symptoms, 80% remained asymptomatic. So, but this is a Western data, I agree with it. Now, if you look at the picture, projection there? Yeah. If you look at this, asymptomatic gallstone, becoming symptomatic is 2 to 3% per year. If they have biliary colic, then 50% patient will have recurrence of symptoms. So that is a separate subgroup. I would not like to debate if a patient had biliary colic, whether to offer gallstone surgery or not. If you get cholecystitis, if patient develop cholecystitis, 30% recurrence in 1 year. And then of course these complications like gallbladder cancer, chronic cholecystitis, pancreatitis, gallstone ileus and so on. So once patient becomes symptomatic, then offering surgery is not a bad idea. If you look at 20-year period, 18% had biliary pain, but you see the timing of probability. 2% in first 5 years, 1% in second 5 years, and beyond 10 years, chances of getting recurrent biliary colic minimizes. So what are the advantages of doing expectant treatment? Expectant means not offering surgery. Majority of the patients will have a benign course. You are offering a surgery, though safe, but not absolutely free of complications with anesthesia or surgery. And then it's a burden on the healthcare system. With a population of 140 crore, if you say that approximately 6% patients or 10% patients have gallstones, you imagine the huge burden for the surgeon to operate. And then you can always operate, and majority of the patients who have complications of gallstone-related complications other than gallbladder cancer, 75 to 80% will have had history of biliary colic. So it's not necessary that you have to operate today. Patient gets biliary colic, you revise your strategy depending upon the factors, both patient as well as disease related. Disadvantage of expectant treatment, chances of complications are of course there, and emergency surgery is associated with what Dr. Rajneesh said was conversion to open cholecystectomy, chances of complications and possible mortality. Now, for me, there are clear-cut indications of cholecystectomy. If the gallbladder has got something which predisposes it to malignancy. Gallbladder polyp more than 1 centimeter, I would not argue. Porcelain gallbladder, it is debatable, I'll discuss later. Some ethnic groups where North Indians come, but North Indians don't correlate with North American Indians as well as South America. There is a difference I'll discuss. Presence of multiple stones, large stones, some say 2.5, some say 3 centimeter. Transplant patients, not all transplants, non-solid organ transplant, mainly heart and bone marrow. And of course chronic hemolytic anemia where they are more predisposed to complications. Now coming to gallbladder polyps. Is surgery needed at all? No. Polyps which are more than 1 centimeter, they should be operated. Polyps which are between 6 to 9 millimeter with associated gallbladder wall thickening or stones should be offered surgery. Approximately 7 to 8% population have got polyps, but only 5 to 7% are adenomatous, which are pre-malignant. So all polyps should not be offered cholecystectomy. Any polyp less than 5 millimeter, you should do nothing. 6 to 9, you can do 6 monthly or yearly ultrasound, good enough to see either they are increasing in size or the character is changing. So this is one concept. Regarding porcelain gallbladder, all porcelain gallbladder should not be operated. If it's a localized punctate type or non-diffuse type of calcification, they are more prone to cancer. If there's a diffuse symmetrical calcification, it is not a pre-malignant condition. So we have to identify subgroup of people who are candidates for surgery because of possible neoplastic transformation. I'm sorry. Now the issue of, Now the most dreaded complication which we are bothered about is gallbladder cancer. India falls in a high prevalence area, approximately 21 to 22 per 1 lakh population. And if you compare South America, approximately 16 to 27. Western data doesn't suggest prophylactic cholecystectomy to avoid gallbladder cancer because chances of getting gallbladder cancer are minimal in Western world. But Indian population a little different. Now India should be divided into North India and South India in the context of gallbladder cancer. Incidence of GBC is almost 10 times as compared to South India, and incidence of symptomatic gallstones is almost 18 to 20 times. So North Indians are more prone to symptomatic gallstones and more chances of having gallbladder cancer. Gallbladder cancer, very poor survival, but the slide, this I want you to pay attention. You look at the South Americans, you look at prevalence of gallstones and prevalence of GBC. They are quite equal. So there is an indication of getting cholecystectomy done because chances of gallbladder cancer are very likely. You look at Indians, 6 to 8% prevalence of gallstone cancer, 22. So they are not going hand in hand. So there is some problem. The problem is this: gallbladder cancer, gallstone is not the only etiology. There are host factors, there are environmental factors, and there are gallbladder factors. So we have to pay attention to each of them. For example, I'm sorry. If you look at female more than 40 years, multipara, tobacco user, morbidly obese, regular use of oral contraceptives, that lady is more prone to get gallstones and possible gallbladder cancer. Infection, mainly typhoid, paratyphoid, and Helicobacter pylori and Bacillus. Now what is more important is vulnerable gallbladder. That is the area which we need to be very careful. If there are large stone, more than 3 centimeter, multiple stones, non-symmetrical or non-diffuse porcelain gallbladder, Mersey syndrome, xanthogranulomatous cholecystitis, anomalous pancreaticobiliary union, mainly in Japan it has been shown, and chronic cholecystitis and with gallbladder stasis. They are the gallbladder which are more prone to get gallstone, more prone to get GBC. This is a study by Dr. Yogesh Gupta which basically showed that 80% patient present with stage 3 and stage 4, they are not, cannot have curative resection. Now the question is if there is such a problem, is laparoscopic cholecystectomy safe? Most of the time it is considered to be a safe surgery, but if you look at bile duct injury, rates have been less than 1%. But what you need to look at is operative time, conversion time to open cholecystectomy, and morbidity. And what you have to realize is that once bile duct injury happens, mortality is 4% versus 1% or less than 1% if bile duct injury does not happen. So if complication happens, it has got associated significant morbidity and potential mortality, though it is an uncommon complication. It's not only bile duct injury. You look at the list of complications. Though in competent hands, it is uncommon, but it's a potential complication which can happen. And why it happens is anatomical difficulty. For example, stone in the Hartmann pouch, stone in the cystic duct, a lot of adhesions there, aberrant anatomy. It's not easy for the surgeon to get it right every time. So there's a potential chance of having morbidity, even if there's a very good surgeon. And if you look at the mortality, more than 65 years, mortality almost becomes 4 times in people who are older. So it has to be seen that which patients are candidate for surgery. Now it's not only about learning curve. If you look at US, approximately 1/3 patient who had more than 200 cholecystectomy, they got bile duct injury. And there's a very good questionnaire-based article by Dr. V.K. Kapoor where they looked at surgeons' opinion, and what they found was that 15% of surgeons had bile duct injury after 10 years of practice of cholecystectomy. And 40% had their first bile duct injury after doing more than 100 lap choles. So basically, it's a safe surgery, but even in a very good surgeon's hand, there are so many variables which decide whether the surgery is safe or not. This has been discussed by Dr. Rajneesh, I'm sorry. But what I want to show on this slide is, this is a South American data, where incidence of gallstones and incidence of GBC go parallel. In India, it is not like that, which I showed in the graph. So we cannot generalize and extrapolate that it works in Chile, it should work in India also. Okay, we need to have long-term prospective study at the natural history of gallstones to see how they behave. This is a study by Dr. Ibrahullah from Bhubaneswar, where they did 122 cholecystectomies, and the incidence of carcinoma in situ and adenocarcinoma was 1.5%. So majority of the patients did not have malignancy. Now, how many cholecystectomy? I don't know. But what I want to say is the risk of developing cancer in all patients with asymptomatic gallstones is less than 0.01%. If you look at all patients, and which is less than the mortality associated with lap chole in India. Okay, even in competent hand, there's always a risk of complications. So all asymptomatic gallstones are not candidates for cholecystectomy. Now this is a 55-year-old lady, obese, with asymptomatic gallstones and thickened gallbladder wall. So what are the risk factors? She is more than 40, she is obese, and she's got an abnormal thickened gallbladder wall. So I would offer surgery to her because she has got multiple risk factors. Okay? But this graph, I want you to pay attention. This is a registry. If you look at males and females, the age-adjusted incident ratio, in male, it increases when the person is beyond 55. In female, the risk increases when the lady is more than 35. So these are the ages where you need to pay attention, that these are more predisposed to symptomatic gallstones and potential complications. Okay? Now, last two slides, I will talk about logistics. Uttar Pradesh population 200 million. Even if you have a conservative estimate of 4% gallstone incidence, 8 million. If one center does 5 cholecystectomy daily for 200 days in a week, they will need 800 such centers to work for 10 years to treat all stones, asymptomatic. And you have to realize that every year 3 to 4% patient will be added. So it adds on to the burden of work. And if you look at bile duct injury, even if you take it 0.5%, there will be 40,000 surgeries needed for complication also with lap cholecystectomy. This is a conservative where good surgeons are working, everything is fine. Then also there is a possibility of bile duct injury. It can happen with anywhere. Hemolytic anemia, I would not argue, they are candidates for surgery. Immunosuppressed patients, they are candidates because the symptoms can be vague. They have more chances of getting fulminant sepsis, so they are candidates for surgery. But then, not all transplant. Renal transplant have shown that there is no advantage doing surgery before doing transplant or after transplant. But in heart and lung, people have shown that you get the transplant done, stabilize the patient. Once the patient is stabilized, doing early cholecystectomy post heart transplant, it's much safer and much better. So basically what you need to look at is you have to look at the patient in toto. Age of the patient, sex of the patient, from where the patient is coming. If patient is coming from south, my threshold of offering cholecystectomy for asymptomatic stone will be much higher as compared to a North Indian obese lady. Family history of gallbladder cancer, definitely a risk factor. Area, multiple local factors, multiple gallstones, large gallstones, porcelain gallbladder, Mirizi syndrome, xanthogrammatous cholecystitis, anomalous pancreatic biliary union, I would offer surgery. And if there is a worsening of symptoms, the new symptoms come up like weight loss, anorexia, right upper quadrant pain, and of course if lump is there, I would straight away go for surgery. So what I would conclude by saying is that there are geographical and ethnic differences. We need to identify patients who are candidates for cholecystectomy in asymptomatic cases. We need to have local data generated so as to say that what should be our policy. And laparoscopic cholecystectomy advent should not make us lower our threshold to offer surgery. And patient has to be a partner in whichever way we want to discuss the patient. We have to balance the risk factors and the benefit of surgery. And of course, quality of life has to be. So it's basically we are trying to balance art and science. There's no right or wrong. Rajneesh is not right, I am not right. We have to see each case individually and decide that which strategy is good for the patient. But what I would conclude is saying laparoscopic cholecystectomy is not a diagnostic therapeutic test. Thank you.
Thank you for your wonderful talks, both the speakers. We can have a couple of questions from the house.
I knew the surgeon will be the first one. Now let the surgeon. Yeah. Cirrhotics have much higher chance of getting asymptomatic gallstones. Now, the whole talk has been philosophical. But what I would say is, child A and child B, they are very good candidates for laparoscopic cholecystectomy. Okay? If they're asymptomatic, prophylactic cholecystectomy I would not ask for. Unless you are doing some surgery where surgeon can do a cholecystectomy along with the main surgery. But I would not offer that you are a cirrhotic, you have gallstones which are asymptomatic, I would not. And anyway, child A and child B can be operated with safety. problem arises in child C. And another thing is that in child A and child B, laparoscopic versus open are equally good. But in child C, laparoscopic should be offered, but complication rates are much higher. I mean, but I would talk to the patient, I would talk to the surgeon also, and then decide. It's not my strategy only, because risk and benefit has to be discussed. I mean,
Good afternoon, sir. Dr. Sameer, sir, I'm Anshuman, and my question to you, number one, it was a very extensive presentation with a lot of theory involved. To a lay person or to a general person who's coming to you, how do you define dyspepsia? I don't think so. There are many contentions about the gallbladder size and thickness and polyps and number of stones. But how would you define dyspepsia? And number two, would you actually offer an endoscopy in your dyspepsia patients? What is the rate of your complication in upper GI endoscopy in dyspepsia? And to Dr. Rajneesh, sir, in the continuation, the contention would be about the incidental gallbladder cancer, for which, for the general information, it is basically that we do not have any impression prior to the surgery of incidental gallbladder cancer. So is it the incidental gallbladder incidence, is it bigger than the incidence of injury, which is less than 1%, or what is the real scenario in our setting?
see, intentionally I removed that statement of relative indication is dyspepsia.
So the contention apparently is dyspepsia, means otherwise you are not calling it asymptomatic. That is what you said.
Dyspepsia is a vague symptom, and studies have shown that 40% people who are operated for dyspepsia, they get recurrence of symptoms. And so-called post-cholecystectomy syndrome, that is now the term has gone. So it's always advisable to rule out alternative diagnosis, for example, reflux disease, for example, peptic ulcer, for example, irritable bowel syndrome. So it's always better to rule out because majority of those patients are not going to respond. Now, in addition to that, one or two studies have shown that approximately 10 to 15% patients, these patients, they have been found to have microliths in their bile. And this has been basically when the hepatic bile has been evaluated. But majority of the patients will not have any biliary cause to explain dyspepsia. So you feel very bad that you offer the surgery to the patient and the patient come back with the same symptoms. Because anyway, there was no indication of doing a cholecystectomy. The only indication is biliary colic or associated complications which include acute cholecystitis, chronic cholecystitis, biliary pancreatitis, chronic cholecystitis and gallstone ileus and cholangitis with CBD stone. For dyspepsia, there is no doubt about it. These patients should not be offered. Older studies have shown that 70% patients respond.
But you do an endoscopy in all these patients?
No, why should you do it? There has to be indication. If their age is more than 45, alarm symptoms, I find anemia. And for endoscopy also there has to be indication. Every dyspeptic, we don't do endoscopy. Regarding complication rate, I'll have to calculate how many endoscopies we have done and when was the last complication. But it should be less than 0.001%.
Any surgeon would say that also for the laparoscopic?
I don't think so, because we deal with bile duct injuries, so we have proof.
So incidental CAGB, sir, that was the question.
Your question was exactly?
Sir, often in all your studies and in your presentations, every physician or every surgeon is talking about the complications in terms of injury to the patient, in terms of bleeding, in terms of this thing. So what about the incidental carcinoma gallbladder incidence, whereby it is actually missed out on the preoperative imaging? Incidental essentially would mean that thickness is normal and everything is normal, and we do not have any preoperative impression of having a gallbladder cancer. So still, as you rightly said, that you have so many patients who have been surviving and they were of incidental type. So what is the incidence of incidental gallbladder cancer vis-a-vis the incidence of injury per se, which is debated against doing laparoscopy?
So that is the question, that's where the penny drops, okay. So we're trying to compare which is better, having incidental carcinoma gallbladder or having a bile duct injury, correct? That is the question really.
Not the right way.
You should have worded it properly, you could have avoided all paragraph. Okay. My impression of this debate and for most things in life is debates are a very bad way of solving problems. Our country is a prime example, so please don't go by what we have just said, because we are trying to show our side of the story. Him, his side of the story, me, my side of the story. I can only put one figure in front of you in vis-a-vis the question that you exactly posed is, one of the figures is non-modifiable, the other is. That is only defense I can put in terms of complications of laparoscopic cholecystectomy.
So thank you both the speakers for your wonderful talks. Thank you.
the debate actually fueled the medical progress, and I request the dignitaries on stage to kindly present, felicitate our debaters, Dr. Rajneesh K. Singh and Dr. Sameer Mohindra, and would request you all to please clap for them. Thank you. In between, I have a quick announcement to make, and I request Dr. Alok Mishra sir to please come up on stage to do that. Thank you.
It's just a request for all the delegates and member of UPIG. At the end of the session, right from the 6 o'clock, we will have the general body meeting of UP chapter, Indian Society of Gastroenterology. Our agenda is to election, next UPIG con venue, and of course, adoption of national ISG constitution and bylaws. As National ISG has directed all state chapters to adopt the constitution and bylaws and to work as per the direction of the national body. So we will have to adopt this constitution in the GBM legally and start fresh with the formation of governing council and selection of the venue for the next year conference. So please be present at 6 o'clock. Whatever time the session ends, we will have the GVM here. Thank you.
Thank you, sir. You need your laptop. As we have to stick to the time, and since we are moving on time, so it's a request to kindly adhere to the time given. And with this, we come to another session, and that is the session on liver transplant. And for that, I am deeply honored to invite the chairpersons on stage, Dr. Prashant Solanki, Dr. Anshuman Pandey, and Dr. Ankur Singh. Welcome on stage, sir. And would request our chairs to please introduce the speaker of this session.
Good afternoon, everybody. I would like to introduce our esteemed speaker, Professor Dr. Abhijit Chandra. He is the professor and head from the Department of Surgical Gastroenterology and also heads the liver transplant department over there. He is from King George's Medical University of Lucknow. And his special area of interest would remain as liver transplant, which he'll be speaking of.
Not that I've been here, and I was here in the morning, as you all know. This is something out of turn, which I'm presenting, I think, perhaps to fill in the gap. But worthwhile mentioning that, you know, how we've so far but started our journey of liver transplant, which had a setback during COVID period. And at the outset, let me again thank Dr. Puneet and Sumit for making me jump the queue and, you know, having this. And this program is actually a program not just, as you know, it's a team effort, and it's the team KGMU which is there, which has actually evolved over a period of 10 years, I would say. So we all know that there's a tremendous gap between the requirement of liver transplant and actual transplants being done in our state. And UP is the most populous state, and it is economically poor. So we need many more centers, you know, here in our state to make this transplant, especially liver transplant, affordable, which is still confined to private sector, and it's really out of reach for many of our patients. Now, our journey started way back in 2013. You know, it's been an arduous journey, and it's been a struggle not just for me but for so many others in KGMU. Sumit has been the sheet anchor for this, and especially in reviving the program post-COVID. And I would say that we are still struggling in 2023, but we have some remarkable stories to tell, which I'll just share with you. It's a very general kind of a talk, but I think people should be aware about what we've been doing. It all started in 2013 when we had an in-house mandatory brain death declaration. You know, not many hospitals still have it in UP, and this was made mandatory by our then Vice Chancellor and the DGME, that every brain death has to be declared as a mandatory, and every ICU in charge was made responsible to do this, and it was obligatory. So this stirred, so-called the program, and we actually started having a lot of brain deaths in KGMU. As you know, it's not a single door hospital. It has many buildings all over the place and about 10 ICUs. So we sort of made surveys initially, and then we thought that unless and until we don't declare brain death mandatory, we won't have any retrievals or organ donations. And then after a long struggle in 2014, we were able to start as a non-transplant organ retrieval center. Until now, I'm happy to share that we've donated almost around 60 donations have been made, and 26 brain dead donors, including 22 livers, have been harvested, 48 kidneys, and of course corneas. And most of the initial retrievals were, they went, first 5 went to SGPGI, and then rest went to Delhi and all government hospitals, and majority went to Army Hospital, RNR, because they had a robust program, and I think 2 went to AIIMS, New Delhi, and few went to private sector as well. Now, as you can see, ILBS of late, ILBS has been one of the beneficiaries of our organ retrieval program, and this was the first green corridor which was established, and liver was transported to Delhi in almost 90 minutes. And this was way back about, I think, 8 years back. A young girl, 18-year-old girl, was the first one we harvested. Now, gradually we learned, and we then made a little publication just to emphasize the amount of organs being generated or the potential to generate it at KGMU. And you'll be surprised to know that, over a period of 6 months, when we just made surveys, there were 99 brain dead who were eligible actually to donate. And on an average, even today, if you make random rounds in ICUs of KGMU, which I've told you are about 10 in number, we have almost 1 to 2 brain death per day. Now, out of these 99 initially, 67 were actually suitable, and we had consent process in 32. This is an old data, which is actually published. So 35 families consented, and this is about pre-COVID times. And out of those, only 8 we were able to retrieve. So if you see, majority of the patients refusing to donate, in-house family issues were the causes. If you see, the cause of negative consent was discord amongst the family members to donate. And then the other reason not to donate was, of course, it was not, surprisingly, not lack of education. It was not economics. As you see, in fact, in our series, more patients who were economically not well off, they donated more than those who were economically well off. And the other major factor was, of course, religion. So we can see that it's not education, it's not just economics which would drive organ donation. Again, this is which I've alluded to earlier. Majority were kidneys and livers, and of course 1 or 2 were combined kidney livers. Finally, in 2018, just before COVID, we were registered for the liver transplant program, first public, I think second after SGPGI, public sector hospital. at KGMU, and then first liver transplant was done just before COVID. And this, of course, I would acknowledge the help of Dr. Subhash Gupta and Max Hospital, who actually helped us and who has helped us to mature into a near independent liver transplant program nowadays. This was again, as you see, about 4 years back. And then subsequently, there were just a few stories about last Diwali, we had actually had a donation again. This was 16-year-old girl who actually donated, and the liver transplant program went back. And just about 4 months back, we had the first cadaveric successful kidney liver transplant program at KGMU, and this was again father of a JR studying in Lucknow, and so far they've been doing well. Now, if you see our transplant program picked up, this is about 7-8 months back, when we had 2 successive transplants in 2 successive days, and both were successful. One was again live-related and one was cadaveric. And of course, we run off, till now we run about 28 liver transplants, and post-COVID, we actually had to restart it. We were actually reinventing the wheel. We had to just do the same thing which was actually at the initial part of starting the liver transplant program. And then if you see 6 cadaveric donations have been possible this year, and overall 28 transplants have been done. And this is the largest, I would say, I'm happy to share that this is the largest number of liver transplants being done in a public sector hospital in the state of Uttar Pradesh. Now, if you see, the costs are enormous. We all know the costs in corporate sector hospitals are enormous, beyond the reach of most of our patients. And this is actually, I won't go into the detail, but this is the distribution of how the costs have been calculated and how cheap the transplant can be performed in a public sector hospital. And this is the worksheet which is there at KGMU. If you see, the total cost is something between 10 to 12 lakhs. And most of our patients are now being funded by the CMPM fund, at least 50% of that. So almost the cost to the patient comes to around between 5 to 6 lakhs. Now, this is the distribution. If you see, majority of our patients have been assisted by CMPM fund, and then there's also an ASAD scheme by the UP government, which helps these patients to tide over the costs involved in this large operation. We have a huge team, of surgeons as well as gastroenterology team, people from anesthesia, transfusion medicine. They were all being circulated to some top liver transplant centers in India and abroad and get trained. And finally, we could gather this team, which is, you can see, very comprehensive, and somehow we were able to keep the team intact over these years, and now it has matured into a successful liver transplant program. Many of our donors have from time to time been appreciated by the government as well as the university administration, and this has triggered, or this has actually encouraged us to take this organ donation program forward. And as you know, ours is perhaps the only, I wouldn't say the only, but it's the most important and one of the highest donating centers in the state of Uttar Pradesh, which is still, I would say, not met its full potential. As you can imagine, we have an enormous frequency of brain death, 1 to 2 per day. Unfortunately, it's still not being translated into actual donations for various reasons, administrative reasons and financial issues and so many other things. But I hope that this continues and our journey still goes on, and we could really translate into more numbers. So this is, in short, what we've achieved so far. And if you see, most of the patients who have been transplanted could never be transplanted elsewhere in any of the corporate sectors. 50% of them were below poverty line, and almost 80% couldn't even afford 2 days' meal. So this is what in short, our journey of liver transplant has been at KGMU for the last 10 days, and it continues. It was initially a retrieval center to begin with, as I mentioned, and it's now matured into a robust transplant program, doing about 1 to 2 per month, which I would say is a good number in our setting, given our constraints of working in a public sector hospital. Most importantly, it is extremely cost effective, as you saw, and it serves the poorest sections of our society. Still, we have a long way to go, and I really thank to all of you for giving me this opportunity and sharing of what we've been doing, which perhaps is not known to many people, but I would encourage everyone to come forward and help us and make it a center of excellence, perhaps one of its kind in public sector. Thank you.
Thank you, Dr. Abhijit Chandra. It was an excellent talk, and it was so inspiring that a government sector hospital is conducting liver transplants, especially for the poor section of the society. Thank you very much.
Thank you. Yeah, I've already.
I request the chairpersons to felicitate Dr. Abhijit Chandra. लखनऊ की आबो हवा ही ऐसी है कि जैसे हम कहते हैं पहले आप, तो आप वाली तहजीब हर जगह नजर आती है. Okay. Thank you. And now I move on to the next session, that is on challenges for clinicians in pancreatic diseases. And I invite the moderators on stage, Dr. Sanjay Tandon, Chairman API Lucknow Chapter, Consultant Physician Lucknow. Welcome, sir. A round of applause, ladies and gentlemen. Applause is, you can raise the applause. We just had lunch. Thank you. Dr. Manish Manrai, Professor, Department of Medicine and GE, Command Hospital, Lucknow. Welcome, sir. And Dr. Piyush Mishra, Consultant Gastroenterologist from Kanpur. The first topic is recurrent acute pancreatitis, how I approach. And I request the chairpersons to introduce our first speaker, Dr. Anup Saraya, sir. And I invite the chairpersons on stage, Dr. Manjul Mishra, Senior Consultant, GE, East Gastrocare and Multi-Speciality Hospital, Prayagraj, Dr. Ankur Yadav, Assistant Professor, Departments of GI Medicine, SGPGIMS, Lucknow, Dr. Gaurav Shrestha, Gastroenterologist, Nepalganj, Nepal, and Dr. Satyendra Kumar Sonkar, Professor, Department of Medicine, KGMU, Lucknow.
Respected Chairperson and members of the House.
Just a minute, sir. I'd like to welcome Professor Anup Saraya here. He is Professor and Head, Department of Gastroenterology and Human Nutrition at AIIMS, New Delhi. Over to you, sir.
So at the outset, I would like to thank Organizing Committee of ISGCon UP for giving me this opportunity to be here. And I'll be discussing various questions associated with idiopathic recurrent acute pancreatitis. These are what is idiopathic recurrent acute pancreatitis, how to investigate, what to investigate, when to investigate. So all these questions will be answered. So what is this idiopathic recurrent acute pancreatitis? Idiopathic means when no obvious etiology after standard investigations can be found. That means after ultrasound, if gallstones are not there, CBD stone is not there, there is no history of alcohol intake or say there is hypercalcemia. All these common causes once we rule out, and then we labeled it as idiopathic. Recurrent means more than 2 attacks 3 months apart, and acute means there is no evidence of chronicity on investigation. And pancreatitis we identify with raised amylase and imaging evidence of pancreatitis. There has been no consensus in how to best define this recurrent acute pancreatitis, but a simplified definition is needed to diagnose recurrent acute pancreatitis early and evaluate its etiology so as to prevent further episodes and progression to CP. So recurrence, how can we prevent, and how to prevent occurrence of CP in this subgroup. A persistent fluid collection secondary to first episode of acute pancreatitis should be ruled out before labeling second episode of pain as recurrent acute pancreatitis. And in practice, CT scan is recommended, if not already done, to exclude CP, means chronic pancreatitis. And more advanced investigations such as MRCP or EUS are not required at this level, at this stage, to label a patient as having idiopathic recurrent acute pancreatitis. As far as our experience is concerned, if we have analyzed our data, 683 patients of acute pancreatitis, and idiopathic recurrent acute pancreatitis was present, idiopathic pancreatitis was there in 22%. So why we investigate? Just to reduce the risk of recurrence. And most patients with acute pancreatitis are at risk of recurrence. And this recurrence generally we see after first episode, around 10 to 15% may have recurrence over a period of time. But after second episode, this percentage goes up to almost double, the 36%. These are the series where risk varies from 11 to 32%. And what to investigate for? It depends on the clinical situation. If a person is young, the line of investigation will be different. In an older individual, after 50 years, line of investigation will be different. And depending on the symptoms, we go ahead with the investigation plan. Despite exhaustive investigation, etiology may not be evident in 10 to 25% of patients with recurrent acute pancreatitis, and recurrent acute pancreatitis may also be considered as an entity with gene-environment interactions and variable host response to the inciting agent. Known and presumed causes of recurrent acute pancreatitis can be grouped into biliary, toxic, genetic, metabolic, anatomical abnormalities. When we talk of anatomical abnormalities, mean ductal abnormalities, neoplastic, chronic pancreatitis, and idiopathics. Other causes which we generally rule out during investigation are role is doubtful, microlithiasis, pancreas divisum, sphincter of Oddi dysfunction, early chronic pancreatitis, occult tumor, and genetic mutations or polymorphisms. As far as toxic etiology is concerned, alcohol and smoking. The prevalence of recurrent acute pancreatitis in chronic alcoholics are around 16.9% in men and 5.5% in women. The most common among heavy then light drinkers, and most patients have early changes of CP at the time of first attack itself. Roughly 10% patients may have evidence of chronic pancreatitis during the first episode itself, and there is a higher likelihood of progression to CP in this scenario. And cigarette smoking is an independent, dose-dependent risk factor as far as toxic this thing is concerned. So here it is important. If a patient is having history of alcohol intake and smoking, we advise them to give up smoking and alcohol so that we can prevent the progression of disease to some extent. Then gallstone disease are a common cause of recurrent acute pancreatitis, and although cholecystectomy and or sphincterotomy provides protection against recurrent acute pancreatitis, recurrence may still occur in 4.4% patients treated with cholecystectomy alone, 6.7% treated with endoscopic sphincterotomy, and 1.2% patients treated with both. Hypercalcemia, again, is an important factor which we rule out in recurrent acute pancreatitis. It's an uncommon but treatable cause of recurrent acute pancreatitis, and hypercalcemia must be ruled out in crescent phase because during the acute episode, calcium level may be low, and we evaluate for parathyroid adenoma in these cases. Hypertriglyceridemia, again, an uncommon metabolic cause, mostly reported from China, and serum triglyceride level is more than 1,000 milligram per deciliter. That can cause pancreatitis, mechanism of which is unknown. And most patients have an underlying familial disorder of lipid metabolism, and since only some patients with HTD develop recurrent acute pancreatitis, so it may be a cofactor required to cause pancreatitis in them. Here we may look, the frequency of CFTR mutation was reported to be high in this group. In alcoholic pancreatitis, serum lipid may also be elevated, and plasma exchange may be beneficial, and newer therapy has been introduced in the form of antisense molecule. Drug-induced, again, there are few drugs which can cause acute pancreatitis. Cause and effect relationship to establish is difficult because re-challenge is not feasible, And the commonly used drugs like azathioprine, fibrate, ACE inhibitors, L-asparginase, and few antiretroviral drugs may be responsible for recurrent acute pancreatitis. Then coming to tumors, especially in patients, those who are older than 50 years. So pancreaticobiliary tumors are uncommon but important cause of non-biliary or non-alcoholic recurrent acute pancreatitis and should be considered strongly in patients of old age. Both benign and malignant regions such as periampullary tumor, pancreatic adenocarcinoma, neuroendocrine tumors, and intraductal means IPMN can be present with pancreatitis in 2 to 7% of patients. They can be diagnosed with CT, MRI, or EUS. For small tumors, EUS is better than other cross-sectional imaging. Now coming to microlithiasis, Dr. Saraswat is there. In fact, those were the days when we were doing bile examination for microliths. It was his thesis topic. And what is this microlith? These are small stones, less than 3 millimeter in size. And actually, these stones are of cholesterol monohydrate plus calcium bilirubinate and carbonate. Similar pathology as in gallstone disease, gallbladder, as the gallstone. So there are 3 different terms which are used interchangeably. One is microlithiasis, biliary sludge, and crystals. Everything is different. As I have told you, what is a stone? Sludge is again, this will not give acoustic shadowing on ultrasound. And here we have mucin, debris, cellular debris, and proteinaceous material. Biliary crystals, again, these crystals you can see in polarizing microscope, under polarizing microscope. These are monohydrate crystals, may be present normally also, but so on the basis of that alone, you cannot recommend cholecystectomy in any patients with recurrent acute pancreatitis. Microliths are gallstones, around 3 millimeter size and can be visualized on abdomen and cannot be visualized on ultrasound. They can be picked up on EUS. The important thing is that there is a study in which they have shown that these gallstone on follow-up means these stones, they'll develop stones over a period of 6 months. And in experimental studies, it has been shown that in a model bile, these stones, small stones, they progress and may develop into a frank stone, gallstones. So if a patient is having microliths, over a period of time, they will definitely develop a stone. These are the pictures, you all are aware of it. So in microliths, what is important? Abnormal liver function test after an episode is very important. If you find deranged LFT, especially ALT more than 2 to 3 times upper limit of normal, the sensitivity is around 85 to 90% for predicting biliary pancreatitis. So what are the clinical variables? Young versus older and duration of disease. If it is more than 1 year, it is unlikely that they will have. There is another study in which they have shown that 27 out of 33 patients with idiopathic acute pancreatitis has positive biliary crystals and they develop stones on follow-up at 6 months. So that is why I say if after one year you are not finding a stone, that means probably the microliths are not responsible for recurrent acute pancreatitis. US better means US can pick up these stones better because they are very small size. And in a study they have shown that 14 out of 18 microliths on EUS, and this was confirmed on surgery also. In another study they have shown that US has a sensitivity of 96% and duodenal fluid microscopy around 67%. So these patients with microliths, 75 patients with idiopathic recurrent acute pancreatitis were subjected. 20 patients were positive for crystals. That was during Dr. Saraswat's time. This study was going on. 10 out of 20 developed recurrence and later CP, even after cholecystectomy and sphincterotomy. So probably we can say that this was not responsible, these microliths were not responsible for the episodes of chronic for the episodes of pancreatitis, and actually the CP was developing anyway, and we were seeing those patients during that phase of evolution of CP. When to suspect? Abnormal liver function test, I have emphasized in the previous slide also. If LFTs are deranged, then we should strongly suspect microliths as a cause. So in older studies, you will find the frequency of microliths was fairly high, but in newer studies, we see hardly 10 to 13% patients were having microliths during examination. So in the absence of abnormal LFT and the presence of microliths on US, role of empiric cholecystectomy is not justified. Coming to pancreas divisum, another entity which is controversial. PD is the most common congenital anomaly of the pancreas and seen in 5 to 14% of general population, and prevalence of PD is higher in patients with recurrent acute pancreatitis. So it was suggested that possibly this is the causative factor, but there was no difference in prevalence of PD in the pancreatitis and non-pancreatitis group in a large series where ERCP was done. So association of genetic mutation like SPINK1 and CFTR in patients with pancreas divisum was also studied, and thus it is increasingly being recognized that pancreas divisum by itself may not cause recurrent acute pancreatitis, but act as a cofactor, and diagnosis of pancreas divisum can be made on imaging studies like ERCP and MRCP. We rarely do diagnostic ERCP these days, and actually MRCP has supplanted ERCP for diagnostic purposes. ERCP is generally performed primarily for therapeutic purpose, and causation of pancreatitis due to pancreas divisum is relative obstruction to the flow of pancreatic juice at papilla. Thus, minor papillary sphincterotomy has been tried as a therapeutic option, but the data which has emerged doesn't even recommend that in all cases. So restenosis rate is around 20 to 30% and may require further intervention if the patient becomes symptomatic after initial response. This is how we diagnose PD by doing ERCP, and the prevalence in various series varies from 5 to 50%. The role, as I have said, the sole factor and significance as far as PD is concerned is doubtful, and if it is associated with genetic mutation, then definitely that may be the cause. So evidence is not overwhelming, probably a cofactor. So what is the question? That should minor papillary sphincterotomy be done in these cases? Possibly yes, but there is weak data in support of that, and a sharp trial which is going on in the US probably answer this question. This we can skip. Coming to sphincter odi dysfunction. Type 1 papillary stenosis, type 2 again doubtful role, and type 3 probably doesn't exist. Prevalence varies from 15 to 48% in different series. So this is a study, 89 patients with idiopathic recurrent acute pancreatitis. They have sphincter of odi dysfunction, pancreatic SOD in 69, and they were subjected to biliary sphincterotomy or dual sphincterotomy, means pancreatic as well as biliary, and both groups have around 50% chance of relapse and 70% recurrence in those with relapse. This data is doubtful whether they were having this entity or not. Now coming to early chronic pancreatitis. As I have said, that after an episode of acute pancreatitis, a significant percent of patients may have recurrent episodes, and gradually they may develop pancreatitis subsequently. So we can say that probably these are the patients of chronic pancreatitis presenting as recurrent acute pancreatitis, and we are seeing them in that phase only. These are the changes which you see on ultrasound, nothing to describe in detail. So 47% of patients with non-biliary and non-alcoholic recurrent acute pancreatitis continue to have recurrent attacks and develop chronic pancreatitis over an 8-year follow-up. In a series of 532 patients, again, after first attack of AP, 13% over 10 years and 16% over 20 years develop chronic recurrence, and this was distinctly increased to 36% after 2 years after the second episode of pain. And meta-analysis also shown that 10% of patients with the first episode of acute pancreatitis and 36% of patients with recurrent acute pancreatitis subsequently develop chronic pancreatitis. So these data suggest that patients destined to develop CP present as having recurrent acute pancreatitis in early course of their disease before overt changes of CP manifest. So many genetic mutations have been shown to be associated with CP, especially SPINK1, CFTR, and PRSS1. And there might exist a continuum forum, a stage of recurrent acute to chronic pancreatitis in the progressive model of disease, the so-called necrosis fibrosis hypothesis. Therefore, the mutational analysis associated with CP might also play a role in causation and progression of this disease. So those destined to develop CP present as idiopathic recurrent acute pancreatitis early during the course of disease. So occult tumor, again, as I have said, patient more than 50 years of age having idiopathic acute pancreatitis, we investigate these patients, maybe having periampullary adenoma or a pancreatic CA, and we keep looking for idiopathic cause of acute pancreatitis. So when to investigate, we do an ultrasound, CT, or MRCP, then followed by US, and rarely we do genetic testing, because the role of genetics testing, again, this comes at the third stage, and it has very limited value outside trials and experimental studies. So in nutshell, patient with recurrent acute pancreatitis, if patient's having alcohol or he's a smoker, then we subject them to CT or MRI to look for evidence of CP, whether they were having CP at the beginning itself, and we ask them to stop alcohol or smoking so that progression can be delayed. If there is none, then in these cases, we look for gallstones, we do a liver function test, and try to detect any abnormality within 48 hours. If yes, that means patient's having biliary etiology, and we do EUS if the abdominal ultrasound is negative, to look for microliths. And if we can ascertain that patient's having a biliary etiology, we can subject them to cholecystectomy or endoscopic biliary sphincterotomy as the case requires. In non-alcoholic, non-biliary recurrent acute pancreatitis, a detailed drug history, family history of pancreatitis, serum calcium, triglyceride levels should be done. And then, if no cause found, then we can do a EUS or MRCP. If gallstones or microliths are present, we can subject them to cholecystectomy. If CBD stone is there, if pancreas divisum or choledococele is there, we can try endoscopic or endotherapy therapy in these patients. If tumor is there, we can subject them to surgery. And if everything is normal, we can do genetic testing to find out whether these patients are prone to develop chronic pancreatitis subsequently, and this is just form-effective of the same disease process which we are seeing at this point of time. So endoscopy, as far as role of endoscopy is concerned, various procedures can be performed in various conditions associated with recurrent acute pancreatitis, but for patient with a clear cause of recurrent acute pancreatitis, endoscopic intervention play a role to treat the underlying disease to some extent. Controversy exists when the suspected cause of RAP is pancreas divisum or type 1 SOD or is unknown. For those conditions, given the lack of evidence showing a clear diagnostic or therapeutic pathway, we recommend referral to center with high endoscopic volumes and possible ongoing clinical trials. So in summary, we can say that idiopathic recurrent acute pancreatitis is a common problem. Early CP may present as idiopathic recurrent acute pancreatitis. Microlithiasis, not a significant cause. We rule out occult tumor. Pancreas divisum, probably a cofactor in idiopathic recurrent acute pancreatitis. Thank you.
Thank you, sir, for such a lucid talk. Do we have any questions from the House?
Sir, excuse me, sir. You mentioned about the ACE inhibitor. Being a physician, we use this ACE inhibitor very frequently in diabetic patients. So we did not come across like acute pancreatitis due to ACE inhibitor. That was a unique point.
See, the problem with these drugs or drug-induced pancreatitis is that to establish a cause and effect relationship is very difficult. It is just the association that we see. The patient was taking this drug and developed pancreatitis. For establishing a cause and effect relationship, you have to re-challenge these patients. That is not possible. And the moment you withdraw the offending agent, pancreatitis also resolves and it never recurs. So we have seen this association with these drugs. But whether these are responsible, that cause and effect relationship has not been established with any toxic drug for that.
Yeah, because we are using very frequently this ACE inhibitor. We can have a large cohort data and can be looked for the association. And what about the patient who are likely to have a recurrent? any baseline investigations like CT finding or amylase lipase or anything else
as I have said,
can,
to make a diagnosis.
apart from the what are evident like hypertension, hypercalcemia, which other patients can be prone and how to prevent them?
You see, it is difficult to say whether these are the causes for acute pancreatitis. But the basic investigation, we always proceed with basic investigation. First, we try to ascertain the history of alcohol intake and smoking. Why, in fact, we investigate these cases of recurrent acute pancreatitis? Just to know the cause so that we can prevent recurrence or progression to CP. These are the two aims with which we investigate. So we try to find out the cause first by eliciting detailed history, and then depending on age, if a patient is coming at the age of say 10-15 years, then obviously you will look for the evidence of say CFTR mutation or SPINK1 mutation. Patient may be having cystic fibrosis, young patient, and we can go for sweat test. But if a patient is coming after the age of 50, then, and if there is no other evidence, then we will look for tumors or some ductal abnormalities or polydipocele, which may be responsible for pancreatitis. So investigation and type of investigation will depend on clinical presentation and various other factors, clinical factors. For making a diagnosis of recurrent acute pancreatitis, as I have told you, the EUS or MRCP is not required. If a patient is having two distinct episodes of pain abdomen 3 months apart, having no evidence of chronic pancreatitis, and after the first episode, we generally do, even if we want to rule out chronic pancreatitis, we do EUS after 8 to 12 weeks, because those acute changes may persist and it may be difficult to rule out.
And other last one, the viral etiology, you didn't mention about any viral etiology leading to recurrent acute pancreatitis.
Viral etiology generally lead to acute pancreatitis. So if it is a viral infection, it will, if once resolved, unlikely to go into chronicity. What are these patients which are more likely to develop chronic pancreatitis? Those who are destined to have chronic pancreatitis, means having, say, genetic predisposition, or those who are having history of alcohol intake and smoking, and if they are not giving up alcohol, or initial stages, there may be just mild ductal changes which we will not be able to pick up on routine CT, or for that matter even MRCP, because there may be changes in the side branches, subtle changes, which we miss at times, and we never make a diagnosis of chronic pancreatitis based on that, until unless we see intraductal calcification or frank ductal changes. So these are the groups, in fact, where more thorough investigation is needed.
Sir, please be on stage. Request the chairpersons and moderators to please felicitate Dr. Anup Saraya. Thanks for the groundbreaking research presentation, sir. A big round of applause for sir. I thank the chairpersons for being here with us. And we move on to the next session. And for that, I invite the chairpersons on stage, Dr. Sugata Narayan Biswas, Consultant GE SRM Medical College, Prayagraj, Dr. Madhur Chaudhary, Senior Consultant GE from Kanpur, and Dr. K.S. Yadav, Consultant GE, Shekhar Hospital, Lucknow. We also have Dr. Abhijit Ranjan with us. And Dr. Ajay Kanpal, Consultant Gastroenterologist, Vedanta Hospital, Lucknow. Welcome, chairpersons. And over to the moderators.
The next speaker will be Dr. Sunil Dadich. He is a senior professor and head department of gastroenterology, SN Medical College, Jodhpur. He will be enlightening us on antimicrobial therapy and nutrition in acute pancreatitis. Over to Dr. Sun.
At the outset, I would like to thank Dr. Puneet and Dr. Sumit and the whole team of UPISCon for inviting me to this August meeting. Next 10-15 minutes, I'll be telling you regarding how to optimize the management of acute pancreatitis, especially in the first 2-3 weeks. And my focus would be on management of nutrition and the antimicrobial therapy. This is the outline of my talk. First, I'll talk about some basics in my favor of pathophysiology of AP. Then I'll talk about the nutrition, and then I'll go to the antibiotics. Acute pancreatitis, as we all know, is divided based on the Atlanta classification into mild, when there is no organ failure, no local complication, moderate when there is a transient organ failure with some local complications, and the severe when there is a persistent organ failure leading to multiple organ failures. And the severe pancreatitis, although it is less common, but it has got a very high mortality. But this is not all. We need to understand what is the basic behind these phases of acute pancreatitis. It has got 2 phases. First phase, there is inflammatory reaction. Basically, the inflammation starts within the pancreas. Once the inflammation occurs in the pancreas, it spills over into the systemic circulation, and in the systemic circulation, it causes a phase called systemic inflammatory response syndrome. And during this time, the person is at risk of developing organ failures. So the high mortality in this phase of acute pancreatitis is because of organ failures, the multiple organ failures. Then the second phase starts after 2 weeks. This phase lasts for 1 to 2 weeks. After second phase, there is a counteractive response to the inflammatory response. This is known as compensatory anti-inflammatory response syndrome. It is CARS. And this counter-inflammatory response syndrome makes the person prone to get infections. So basically, the inflammation starts within the pancreas, and then it spills over onto the, I don't know if it is not seen properly. It spills over onto the systemic circulation, which is SIDS, and during a phase in between, there is a mixed antagonistic response syndrome, and later on, the anti-inflammatory phase takes over, and this makes the person prone to get infection. So there are 2 phases of mortality and morbidity. In the first phase, the person is prone to develop organ failure and its related mortality. In this late phase, the person is prone to develop infections and its related organ failure and mortality. So what happens to nutrient metabolism in acute pancreatitis? There is abnormal metabolism of proteins because a lot of inflammatory markers are released, which are all protein bound, and there is a lot of protein catabolism, and the person remains in a negative nitrogen balance. There is a hyperglycemia. You can see the blood glucose is there in many of the prognostic scores. Hyperglycemia occurs because of increased neoglucogenesis, decreased insulin secretion from the pancreas, and the insulin resistance. And the hyperglycemia predict the occurrence of severity of severe pancreatitis, and it's a worse mortality. Hypertriglyceridemia is also seen in acute pancreatitis because of the vasolateral release of pancreatic enzymes. And there is a malnutrition and maldigestion because of reduction in the secretion of pancreatic enzymes. There is a hypocalcemia because of saponification of the pancreas. And this leads to the increased resting energy expenditure in the person. The resting energy person can go as high as 126% in patients who have severe pancreatitis because of inflammatory response and because of the response of stress hormones. So how do you feed these patients then? The age-old concept was to give pancreas rest. Why? What was the basis? If you feed these patients, it will stimulate the pancreatic secretion. The increased secretory response of the pancreas will lead to more cellular injury, will cause more fluid collections. So the pancreatic rest was the best concept. The pancreatic enzymes are reduced in severe pancreatitis depending upon the severity. So if you give them, keep on giving them the enteral nutrition, the pancreatic enzyme secretion are more stimulated. But this concept was more of based on physiological assumption, not supported by any scientific evidence, and injured acinar cells cannot fully respond to physiologic stimuli. So the another aspect of keeping the person fasting is, when you keep the person fasting, there is a gut mucosal atrophy, there is increased gut permeability, and that will lead to infection. So the intestinal alkaline phosphatase is a gut mucosal defense It is a protection against the enteral infection, a translocation of bacteria across the wall. This is the best scientific evidence which we can have when you have a meta-analysis of randomized controlled trials. This is the topmost scientific evidence which we have in our practice. So this is a meta-analysis of randomized controlled trials. 11 trials used comparing whether to give enteral nutrition or parenteral nutrition in the first week of acute pancreatitis patient. And you can see all the diamonds are on one side. So enteral nutrition significantly reduces the risk of mortality, infection, complications, rate of multi-organ failure, and the surgical intervention. Also, it maintains the gut integrity, gut function, gut-associated lymphoid tissue functioning, and the gut microbiota composition. It also reduces the bacterial translocation across the wall, which is the most common cause of infection and morbidity in the later phase of acute pancreatitis. So, when managing the nutrition in acute pancreatitis, there are various issues. One by one, I will discuss these issues. When to start feeding, how to start feeding, oral versus tube feeding, NG versus NG versus NJ feeding, nasogastric versus nasojejunal feeding, or how much to give, enteral versus parenteral nutrition, and which feed formula to be used, normal, elemental, or a special formula. Before starting nutrition in acute pancreatitis, we need to evaluate what is the nutritional deficiency. Malnutrition, as we all know, is associated with the negative outcomes. So nutrition should be planned and it should be based on the severity of acute pancreatitis. We need to evaluate the nutritional status and we need to identify the risk factors. The high risk groups will have the higher nutritional deficiencies and a high risk of morbidity and mortality. These high risk groups can be the the chronic alcoholics, obese patients, and the patients who are elderly. Patient who is in ICU, how to assess the nutritional assessment? It should be done based on the Nutric score. A Nutric score more than 5 means the person is nutritionally deficient and it requires a nutritional supplementation. In mild pancreatitis, since it's a transient self-limiting illness, resumption of oral diet should be as soon as when the person is pain-free. And you can right away start with a full caloric solid diet. There is no need to go from stepwise from oral liquid to semi-solid to solid. And tube feeding is only recommended when the oral nutrition is not possible for a week or 5 to 7 days. Whereas in severe or moderate to severe pancreatitis, you need to calculate the requirement. You need to calculate what supplements we need to give. The calorie requirement is as in a normal person, slightly higher than that, 25 to 30 kilocalorie per kilogram per body weight per day. Carbohydrate should be 3 to 6 gram per kilogram. Lipid is 2 gram per kg. Protein is higher than the normal, 1.2 to 1.5 times. In patients who have systemic inflammatory response syndrome, the carbohydrate, total component of carbohydrate should be reduced to 10 to 15% because if you give more carb in these group of patients, it will enhance the systemic inflammation because of increased insulin secretion, and the insulin becomes, it stimulates the pro-inflammatory hormones. The standard formula should be used, mixed source of carbohydrate, fat and protein. There is no need for glutamine supplementation, and the daily dose of multivitamins, trace elements, and micronutrients should be given. Immune nutrition, pre and probiotics are not advised. So, which route to prefer for severe or moderate to severe? The preferred route should be the oral or the enteral feeding. It should be started as early as possible, as the person is pain-free and is stable hemodynamics and his ILS is over. There is a study comparing early refeeding versus the late feeding within 24 hours or feeding after 72 hours. It's again systematic review and meta-analysis. And it shows that enteral nutrition within 48 hours is associated with significant reductions in mortality, infectious complications, multi-organ failure, and the surgical interventions and the length of hospitalization. So the feeding should be started as early as within 48 hours of admission. Which feeding should be used, continuous or bolus? We should prefer the continuous feeding over the bolus feeding because of better tolerance and the fewer interruptions. What about the nasogastric or nasojejunal? Earlier the thing was, if you feed them in the stomach, it will stimulate the pancreatic secretion, it will further enhance the severity of pancreatitis. But now there are studies which says that even if you deliver the food in the jejunum, it will stimulate the pancreas. And I told earlier, the injured acinar cells fail to respond to the physiological stimuli, and they don't over-secrete the pancreatic secretion. It is already less. So nasal feeding is as good as the nasojejunal. So nasogastric feeding is as okay, because it is technically easier, can be placed by any non-medical or any nursing person. It is cheaper, easier, and it is less time consuming. It's good for the patient also. Which formula to use? Polymeric versus semi or elemental, semi-elemental formulas. When you compare the enteral nutrition using the various formulations, this is again a meta-analysis and the systematic review, which shows that polymeric diet compared to the semi or elemental formulation does not lead to a significantly higher risk of feeding intolerance, infectious complications, or death in patients with acute pancreatitis. So you don't need these costly elemental or the semi-elemental formulas. The polymeric formulas are as good. What about the parenteral nutrition? It is indicated only in patients who cannot tolerate the enteral nutrition. If you want to start enteral, it should be delayed at least for a week, because to decrease the complication. It is indicated only when there is intestinal failure due to severe ileus or a renal obstruction due to edema or a fluid collection. And you should prefer a combination of all three major macronutrients. This is how the summary of the use of the fluid or the route in the acute pancreatitis. Mild, you can straightaway start for oral. For moderate, on demand in ICU, you can start orally. Even if it is severe in ICU, you should first prefer enteral nutrition orally. If not, then nasogastric. If not tolerated in nasogastric, then you can go for nasojejunal or parenteral if it is needed. So what are the do's and don'ts of enteral feeding? Enteral feeding, nutrition in acute pancreatitis, enteral feeding is preferred. First 48 hours, start feeding. That will reduce the infectious complications. NG is good, preferred over the NJ. The standard polymeric diet is good enough. Don'ts, don't use parenteral unless indicated. Don't use NJ unless indicated. And there is no role of these sophisticated nutritional supplements. What does the AGA guideline says? ADA guideline says to start feeding within 24 hours as soon as the person starts tolerating the feed. And the person who cannot tolerate orally, then they recommend the parenteral nutrition only in a special situation. And then in people with predicted severe necrotizing pancreatitis who require tube feeding, both NJ and NG can be used. The second part of my talk is on antibiotics in acute pancreatitis. I'll discuss under three headings: prophylactic antibiotics, antibiotics for infected pancreatitis, and how to choose the antibiotics. Prophylactic antibiotics, if you go through this meta-analysis of randomized control trials, go here, see here, the early trials, 90s and early 2000, all trials shows significant reduction in mortality and the incidence of IPN when you use the prophylactic antibiotics. But the later studies, later RCTs done 2008 and later, failed to show this same thing. And again, there has been some benefit of using prophylactic antibiotic in treatment of extra pancreatic infection, but not the prevention of pancreatic infections. So antibiotic prophylaxis, again, if you use antibiotics from the day one, it will increase the prevalence of MDR as well as the fungal infection. So the routine prophylactic antibiotic for all patients with acute pancreatitis is no longer recommended. What is the mechanism of infection in acute pancreatitis? Again, I told you there are three things. First, there is a milieu, there is a fluid collection which is ready to get infected. And then second, there is a systemic inflammatory response. This is compensatory anti-inflammatory response syndrome. That means this is a systemic milieu which is against the inflammation. So inflammation is reduced, the body is prone to get infections, the body is immune deficient. And at the same time, if you don't give them orally, the intestinal permeability is also increased. So all these three factors leads to infected necrosis in the later part of the illness. And I told you, inflammation starts in the pancreas, goes to systemic circulation in the first page. At the same time, cause start, but in the later part, the cast takeovers. Once the cast takes over, the person is prone to get infections, and it causes the complications. What is the source of infection? As we are discussing always, the source is because of increased permeability, bacterial translocation, immune dislocation, dysregulation. These are the intestinal bacterias, bacteroids, proteobacterias, enterobacteriaceae, which are the commonest cause of infection in these patients. So how to use antibiotics? You need to have a good diagnosis. You need to time your antibiotic properly, and you need to follow the clinical science, but sometimes the science may be confusing. How to choose antibiotic? What is an ideal antibiotic? It should have a full spectrum against both gram aerobic and anaerobic gram negative, as well as gram positive microorganisms. It should be able to penetrate the pancreas, as well as it should be able to penetrate the pancreatic tissue, which are outside the pancreas or which are infected. And then penetration-wise, antibiotics can be high: carbapenems, fluoroquinolones, metronidazole, and Clinda. Intermediate are third generation acyl-iridopenicillins and cephalosporins. Low is aminoglycosides. Can we guide our antibiotic therapy based on the procalcitonin? Yes, there are studies where they have compared the procalcitonin guided care versus the usual care. The procal was done on 0, 4, and 7, and then weekly thereafter. And you can see the procal based patients require less antibiotic. Again, the days of antibiotic use was less compared to the usual care. So the procal guided therapy can reduce the antibiotic use without increasing the infection or harm. This is a data from China. This is audit of all of the country infection in patients with acute pancreatitis, over 2,000 patients. Bacterial profile and resistance, antibiotic use, and they also use the logistic regression to look for the risk factors for culture results, and the culture results correlation with the mortality. The enteric bacteria was the most common. High sensitive antibiotics are carbapenems, penicillins, 5th generation cephalosporins, linezolid groups, and some with aminoglycosides. These are the bacteria which were common: Enterococcus, Staphylococcus. Factors related to positive cultures means number of antibiotics, length of stay in hospital, length of stay in ICU, and mechanical ventilation. Factors related to MDR bacterial infections are age, hemoglobin, length of stay, and duration. It is the positive culture which was independent risk factor for in-hospital all-cause mortality on multivariate regression analysis. So, infected pancreatitis, seen in only 1/3 of patients. They need to be drained and cleaned properly. Similarly, fluid collections needs to be drained and cleaned properly. Minded antibiotics are only supportive treatment in these group of patients. These group of patients should be drained depending upon whether they are walled up necrosis or they are fluid collections. Use the step-up approach to drain them. So the do's and don'ts of antibiotic uses, they should be used only when there are documented infection. Prophylactic use is not recommended. So ladies and gentlemen, to summarize, the first week of treatment of acute pancreatitis is very crucial. We have to use the adequate analgesia, optimum hydration, no antibiotics in first week, early enteral nutrition. Infected necrosis should be treated conservatively first and then drained, and the supporting antibiotics needs to be used. What is the future? How to decrease the mortality? There are many unmet needs. We don't know how to suppress systemic inflammation. We don't know how to prevent necrosis, and we don't know how to prevent infection, and we don't know how to treat the organ failure. We need targeted therapies for organ failure. Thank you very much.
Thank you, sir, for the comprehensive talk. I'm afraid we don't have time for questions. Anybody interested can contact sir outside on a cup of coffee.
Sir, I request you to please be on stage. I request chairpersons and moderators to felicitate Dr. Sunil Dadij. A round of applause, please. Thank you. Thank you, chairpersons, please, for being here with us. And now we are moving towards this, the last talk of this session. And that is, for this I invite the chairpersons, Dr. Ashik Hussain Dar, Consultant GE, GSVM Medical College from Kanpur. Dr. Anil Gangawar, Senior Consultant, VPIMS, Lucknow. Dr. Deependra Khadka, from Consultant Hepatologist and GE, Nepalganj, Nepal. And Dr. Nirupam Prakash, Secretary, UP API, Lucknow Chapter. Welcome on stage, sir. Over to the moderators.
For the last talk in this session, invite Dr. Sandeep Nijavan. He is a senior professor and head of Department of Gastroenterology at SMS Medical College, Jaipur, and he is the national president of Indian Society of Gastroenterology. Sir, I'll request in view of paucity of time if the talk can be precise.
I'm always precise.
Yes, sir.
Yeah. Thank you, Chairman. Ladies and gentlemen, at the outset, I'd like to thank Puneet and the entire team of ISGCon UP chapter for the kind invite, and I bring greetings from Governing Council of Indian Society of Gastroenterology. My topic is pain management in patients with chronic pancreatitis. You all know actually chronic pancreatitis is a fibroinflammatory syndrome. So it has inflammation and fibrosis going on together in chronic pancreatitis, and it actually culminates into presence of pain because of parenchymal distortions, and it also leads to exocrine and endocrine dysfunctions, and later on it is a predisposing factor for development of carcinoma of pancreas. As far as pathophysiology of pain is concerned, there are wiring problems and plumbing problems. Wiring problem means the neuropathic problems, that means the nerve damage at the level of pancreas, and then nociception problem, sensitization at the level of spinal cord and the cerebrum. And plumbing problem means it's basically a fibrotic disease, so pancreatic duct hypertension, and then there are various complications that occur along with chronic pancreatitis like pseudocyst. There can be duodenal obstruction, small intestinal obstruction, even peptic ulcer that can also lead to pain in the abdomen and splenic vein thrombosis. So primary pain is because of ductal hypertension, ongoing inflammation and tissue ischemia. There is altered nociception and some cholecystokinin related changes in the pain threshold, and this nerve damage at the level of pancreas and peripheral and central sensitization leads to pain. There are certain secondary causes of pain because of pseudocyst, inflammatory mass, small intestinal strictures leading to intestinal obstruction and development of adenocarcinoma, or there can be actually remote complications along with chronic pancreatitis, that means bile duct obstruction, duodenal obstruction, peptic ulcers, even bacterial overgrowth can have some pain, and associated small bowel strictures, mesenteric ischemia. And if these patients undergo surgical and endoscopic complications, again they can have pain, and there can be adverse reaction even to the actually analgesics. So there are two types of pains. One is the intermittent pain, type A pain, in which in the intermittent period there is no pain, and there is type B pain in which there is actually intermittent increase in the pain, but there is a continuous pain. Now these actually type B pain are more associated with complications of the chronic pancreatitis, and for the treatment we have different modalities. Risk factor modification should be there, they should be off alcohol and smoking, and then we should actually minimize the ductal hypertension if it is there, and there is a step-up approach for analgesics, invasive procedures if required, and treatment of associated anxiety and depression, neuromodulation, and some experimental therapies. So as far as actually analgesics are concerned, it's a step ladder pattern. Initially we start with non-opioid therapy if the patient has got mild pain. If it is a moderate pain, we go to weak opioids, and ultimately moderate to severe pain, we have to take the assistance of severe strong opioids. Stepwise escalation of drug is
demand because of the increasing potency of the drugs for the severity of the pain. Paracetamol is the preferred non-steroidal anti-inflammatory we actually tend to avoid because of GI toxicity. There are some actually adjuvant analgesic which are to be added like antidepressant, anticonvulsant, anxiolytics and pregabalin also has been tried. As far as opioid analgesic concerned, we use tramadol because it's a preferred one. It's a weak opioid agonist activity along with certain other actions it has got. Then somatostatin analogs inhibit the pancreatic secretion but have not been tried in patients with pain with chronic pancreatitis. And other therapies like clonidine, benzodiazepine, antipsychotics, cannabinoids, these are actually can be tried in difficult cases where pain is not getting under control. As far as pancreatic enzymes are concerned, in 2009 from PGI Chandigarh there was a review, systematic review was there, and they evaluated the change in frequency of abdominal pain, duration of pain, intensity of pain, weight loss, steatoria and quality of life. There were 10 trials involving 361 patients. All trials were randomized, and pancreatic enzymes for the abdominal pain, weight loss, steatoria and analgesic use and quality of life were equivocal. There was another meta-analysis and systemic review was there in 2016, where actually 4 studies with the enteric-coated tablets failed to show any improvement in pain, and only 1 study in which non-enteric-coated enzymes were used. There was some reduction in pain, but it was also not statistically significant. So pancreatic enzyme supplement do not seem to actually relieve the pain and should not be prescribed solely for this purpose. As far as oxidative stress is concerned, it causes cell damage in the pancreatic parenchyma, cell destruction. There is depletion of antioxidants in the cells, and there is toxicity from the free radical peroxidation products. So initially free radicals block the exocytosis in the acinar cells. There is increased autophagy there. So the pancreatic enzymes are diverted into the interstitium, degeneration of mast cells occur. It leads to inflammation and pain. So there are studies with antioxidant role in patients with chronic pancreatitis. The antioxidant use high doses of vitamin C, E, beta-carotene, selenium and methionine, all the studies. And initial studies had less number of patients, though there was some decrease in the pain. But later on there were 2 studies, actually randomized control study. One was from AIMS group by Pramod Garg's group, in which actually antioxidant group, there was a reduction in number of painful days per month, reduction in number of analgesic tablet required per month, and total number of patients became pain-free, almost 1/3 became pain-free, and this study included 120 patients. So antioxidant supplementation, according to this study, was effective in relieving pain and reducing levels of oxidative stress in patients with chronic pancreatitis. Then came the Anticipate study from UK, in which actually it was a double-blinded randomized controlled trial, nicely done. 70 patients with chronic pancreatitis were taken, and pain scores were actually similar in both. It was a 6-month trial. Again, the AIMS trial was also 6 months, and the pain score relief was not statistically significant as compared to the placebo. The difference between the 2 studies was that the AIMS study had young patients. They had more 2/3 patients who had tropical pancreatitis, and 1/3 were undernourished, and 1/3, around 30% were smokers. But the subgroup analysis showed that even patients with alcohol etiology in this study also did not get benefit with antioxidants. And the UK study actually had more patients who were actually more than 50 years of age, and primary etiology was alcohol. They were not undernourished, and mind you, 80% were smokers. So there was a bit of heterogeneity among the 2 groups, and then a study came from AIG group, in which actually, after doing the endoscopic therapy, these patients were followed for 2 months with pregabalin and antioxidants versus only antioxidants, and given for next 4 months. And it had shown that there was a significant relief in pain recurrence after the ductal clearance if they were given antioxidant with pregabalin. So a systemic review lately came up in 2020, total of 352 patients. Pain reduction was not significantly different in antioxidant group as compared to the placebo. So antioxidants, though they were actually safe, they did not have any much adverse events, but there was no significant reduction in pain or change in quality of life in patients with chronic pancreatitis with pain, and use of antioxidant at present stage is questionable. It has to be given to a highly select group. As far as endotherapy is concerned, the aim is to relieve the ductal hypertension. It can be achieved by doing a pancreatic sphincterotomy, stricture dilatation, stent placement, and there are stones, then they can be subjected to ESWL followed by ERCP. The choice of treatment and the initial workup, the recommendations are that the first line of therapy is ESWL for patients with painful chronic pancreatitis with an obstructed main pancreatic duct in the head and body of pancreas. And if there is no persistent pain relief, or they technically fail, or if the patient is not a good candidate for endoscopic therapy and ESWL, medical management including analgesics and adjunctive treatment is high on cards. The final step, those patients who do not improve with these analgesics, surgery can be done in patients who are non-responders. In pancreatic strictures, the target is to decompress the main pancreatic duct, thus decreasing the pain, and it should be done in patients with those who have a dilated duct till the head. And if there is a short single stricture in the MPD in the head region, these are the ideal candidates, and not are the candidates. Those who have poor response will be those who have multiple strictures with chain of plaque appearance. The plan of stenting is to exchange the stent every 2-3 months, and they can be kept for 1 year. The dominant MPD stricture can be decided if there is a upstream dilatation of 6 millimeter, or you push in a 6 French catheter and contrast is not coming out, or you infuse 1 liter through the nasopancreatic drain and for 12 to 24 hours, and they get similar kind of pain. So that's how you actually define the predominant stricture. There are various studies which show that the technical success in dominant strictures is around 70 to 90%, and the improvement of pain is quite good. It is around 70-90%. So you have to select out the patients for the actually correct treatment by endotherapy in patients with pancreatic strictures. As far as pancreatic stones are concerned, they are usually single. They are found in the head, and most of them are radiopaque, and the prevalence increases with time. 50% will have at 5 years, and almost 100% at 14 years. So the more the duration of chronic pancreatitis, the chances of pancreatic stones are high. ESWL for the clearance of stones, if the stones are larger than 5 millimeter and located in head and body. Endoscopic ERCP therapy if they are smaller than 5 millimeter, and endoscopy alone, actually if you compare, for the removal with the basket of balloon, it's only 9% of the total. So endoscopy alone is not the treatment of choice. You have to actually combine that with ESWL. The principle of ESWL is actually electromagnetic source, shock waves on the calculi. It leads to compressive stress that leads to actually breakage of the stone and fragmentation. So there are various studies in which actually interventions are being done with ESWL and endoscopic pancreatography, and if you combine the two, the success rate is quite high, around 70 to 80%, and you have to select out these patients, those who have predominantly disease in the head, and they have got stricture in the head and the stones which are actually smaller, they will respond better. But there are complications of ESWL like pain at the site of the shockwave delivery, skin ecchymosis, abdominal pain, hemophilia, perineal hematoma, bowel perforation, splenic rupture, lung trauma. So there are actually, complications which can occur with ESWL. So it is not at all totally a safe procedure. And factors which favor the complete stone removal are 3 or fewer stones, stones confined to the head or body of pancreas, and absence of downstream stricture. If there are associated stricture, that's a poor response, and stone diameter is less than 10 millimeter, and absence of impacted stones. These are the factors which favor a better outcome. Predictors for the success of ESWL and endotherapy: decrease in MPD diameter, short duration of the disease, absence of MPD strictures, and there is no current smoking by the patient. Contraindications for endotherapy, of course, duodenal stenosis, if you are suspecting carcinoma and a non-dilated pancreatic duct, and lack of expertise. Complication of pancreatic endotherapy: acute pancreatitis may be there, cholangitis, pancreatic duct rupture may be there because if you start dilating very hard the pancreatic strictures, or there can be inward migration of the stent. EOS-guided celiac ganglion block, it leads to transient hypertension in 20 to 40% and transient diarrhea in 4 to 38%, transient increase in the pain in 9% of the patients. There is a systematic review in which actually 6 chronic pancreatitis patient studies were identified, 221 patients, and it has been shown that only 50% in only 50% cases there is response in the abdominal pain, but mind you, these patients can get recurrence of the pain on a long-term follow-up. So ACG recommendations are antioxidant therapy for chronic pancreatitis with pain. It is recommended, although the benefit is limited, so select out the patient and give them antioxidant therapy. Pancreatic enzyme supplements are not recommended. Celiac plexus block, again it is conditional, you have to select out the patients for giving this treatment, and surgical treatment is recommended if the first line approaches like endoscopic approach have been exhausted or is unsuccessful. So the take home messages are enzyme and antioxidant therapy have a limited role in pain with chronic pancreatitis, and in endotherapy preferably it is the first line of treatment in centers with expertise, and it is highly effective in patients, those who are having a high surgical risk, and more so if this endotherapy is combined with ESWL, and it can also actually serve as a bridge to therapy, that is surgery. And EUS-guided blocks, the recurrence is quite common. Thank you for your kind attention.
Thank you, sir, for such a comprehensive talk, well within time. I'm afraid the organizers have said we don't have time for questions. Anybody interested in discussing more with sir can do it, or a cup of coffee outside.
Yeah. Thank you. Thank you.
Sir, please, on stage, please, sir. Please, sir. I request the moderators and chairpersons to felicitate, sir. Dr. Sandeep Nijhawan for the wonderful presentation and for being in the time limit. Thanks for that, sir. Now we are moving towards our last session for day 1. And I thank the chairpersons, moderators, and the speakers for such wonderful talks. We are moving towards
Surveillance. Let us look at the evidence. Liver cancer is the fourth highest cause of cancer mortality after lung, breast, and colorectal. Liver cirrhosis is the most important predisposing condition for HCC, and the incidence of liver cancer is about 1 to 4% in patients who already have cirrhosis. So HCC, if detected at an early stage, can be cured. So if it is detected at early stage, that means according to BCLC staging, if it is detected at stage 0 or stage A, then we have curative treatment to offer. But if it is detected at a later stage, stage B, C, and D, then we can only offer palliative treatment. The WHO criteria for any cancer surveillance says that for surveillance to be effective, the cancer should be common, it should have high mortality, the high risk population should be identified, and the tests for surveillance should be acceptable, and there should be effective treatment available. So HCC meets all these criteria. HCC is the 6th most common cancer. It has got very high mortality, 4th most common cause of cancer mortality. The HCC has high risk predisposed population, that is cirrhotics. HCC has an acceptable test for screening, and if it detected early, then it has got effective treatment. So there are two facts. Cirrhosis is the predisposing condition for HCC, and early detection of HCC has better chances of cure and survival. So there is a definite role of surveillance for HCC. In the guidelines which INASIL published in 2014 and then subsequently in 2019, where we covered all the diagnosis as well as surveillance part, the guideline says that patients with cirrhosis, child A or B should be subjected to surveillance, and even child C cirrhotic patients who are listed for liver transplantation should be subjected for HCC surveillance. And even patients who do not have cirrhosis, but the patients who have chronic hepatitis B with high risk of HCC, or even those patients with HCV with advanced fibrosis should be subjected to surveillance. And the surveillance modality is 6-monthly ultrasound by experienced personnel plus additional alpha-fetoprotein screening is recommended. So once cirrhosis is diagnosed, then these patients should undergo surveillance at every 6-monthly interval. And whenever the small HCC is diagnosed, this patient should ideally be subjected to a curative therapy. And after curative therapy is achieved, again these patients should continue with HCC surveillance. And does surveillance improve survival? So there's a large meta-analysis which has included more than 15,000 patients in 39 trials, and the results of this meta-analysis is that surveillance detects early tumor, and patients diagnosed by surveillance were significantly more likely to undergo curative therapy, and thus these patients had better survival. So definitely there is evidence to suggest that surveillance improves survival. So what are the tools for HCC surveillance? We have imaging tools, that is ultrasound and then CT or MRI, and then we have blood-based biomarkers such as alpha-fetoprotein, PIVCA. I'll go over one by one. So ultrasound is widely available, it is non-invasive, there is no radiation exposure, and it is not expensive, well tolerated, and when performed by an experienced operator, the sensitivity for early detection of HCC ranges between 60 to 80%, but specificity is also very high, 90%. But disadvantages, it is operator dependent, and we need experienced personnel, and unsatisfactory diagnostic accuracy because the sensitivity is between 60 to 80% only. What about CT and MRI? Advantages that it improves the detection rate compared to ultrasound, and even those patients who have nodular liver or heterogeneous morphology, or even those patients who have obesity, it can pick up lesions on CT or MRI, but disadvantages are higher cost, so cannot be used for surveillance strategies. availability may not be good at remote places, and again with CT scan there will be radiation exposure. So there has been a randomized study which has compared ultrasound for surveillance versus CT scan, and it has been found that ultrasound is more cost effective than CT scan, and the cost per HCC detected is much less with ultrasound. What about alpha-fetoprotein? It is most widely tested biomarker, but as a surveillance tool has got suboptimal performance. And its concentration or its level is related to tumor size. So it would detect tumors at an advanced stage, but unlikely to detect tumors with a smaller stage. And it can be raised in other conditions such as chronic hepatitis B, chronic hepatitis C, cholangiocarcinoma who do not have HCC. So sensitivity is 68%, specificity is 80%. So it will miss HCC in about 32% of patients. And also in those who has got false positivity, it will lead to, in 20% of patients, unnecessary test and cost. Combination of ultrasound plus AFP, with this combination there is marginal increase in detection rate, but again huge increase in cost due to false positive rates. What about PIVCA2? PIVCA full form is prothrombin induced by vitamin K absence, and it is also known as DCP or des gamma carboxyprothrombin. It is an abnormal form of prothrombin which is increased in patients with HCC. It is due to an acquired defect in the carboxylation of the prothrombin in the malignant HCC cells. So prothrombin, PIVCA2 may be elevated under vitamin K deficiency and under certain antithrombotic therapies such as warfarin therapy. There has been meta-analysis in the role of PIVCA, which was published in 2018 in the, for diagnosis of HCC, and the sensitivity for diagnosis of HCC was about 80% and specificity was about 90%. Comparing PIVCA with alpha-fetoprotein, PIVCA is certainly better than alpha-fetoprotein. What about AFP L3 function? It is usually not available in India, only available in research setting, but it is, its sensitivity is lower, 50%, but it is, has very high, 97% of specificity, and studies are limited. So all these three biomarkers are independent. So there may be patients who have only AFP elevation, or only DCP elevation, or only AFP L3 elevation, and there will be patients with HCC who will have none of the elevation of these biomarkers. So if we combine these biomarkers, we will have a higher sensitivity as well as higher specificity in detection. What about other biomarkers? There has been Golgi protein 73, glypican, HSP 70, microsomal RNAs, but there's not much data on them. What should be the interval of surveillance? Although the exact interval is not known, but it is dictated by the rate of tumor growth and detectability. So HCC volume doubling time is heterogeneous, but it is on average about 6 months. So a 6-monthly interval seems to be a reasonable interval. So in the 2019 update on INASIL guidelines, we mentioned that 6-monthly ultrasound and AFP should be done. What are the gaps in HCC surveillance in India? So we did a survey way back in 2014 among the gastroenterologists. We sent survey to around 1,300 gastroenterologists. About 400 of them responded, and the results of the survey is that incidence of HCC is increasing. It is the most common etiology that time was hepatitis B, which was responsible for about 43% of cases. 90% of gastroenterologists do screen for HCC when they first evaluate cirrhotic patient. But while following the patients of cirrhotic, only 60% of gastroenterologists screen for HCC every 6 months, and only 14% of patients present at early stage where curative treatment can be offered. So what are the challenges for HCC surveillance in India? The number one challenge is that we have a huge population of cirrhosis in India, and this population is due to hepatitis B, hepatitis C, alcohol, and NFLD, but only a minuscule population of these cirrhotic patients are undergoing surveillance. And majority of these cirrhotic patients are not undergoing surveillance because there is lack of awareness among the physicians who are managing these patients. These patients are managed by non-specialists. Some of these patients are following alternative medicines. There could be financial reason, and many of these patients could be undiagnosed cirrhotic patients. So what are the solutions? We have to increase the awareness about HCC surveillance among the gastroenterologists, among physicians, surgeons, lab personnel, and radiologists, and we should also increase the awareness among the patients who are diagnosed as cirrhosis, and we should tell them that they are at higher risk for liver cancer. The other challenge, even in those patients in whom the surveillance is being done, there is low sensitivity and specificity of alpha-fetoprotein, and radiologists are not tuned for picking up small lesions. And in nodular liver or dysplastic nodules, there's challenge to detection of these patients. So the solution that we can add PIVCA in the surveillance modality as one of the tumor markers, apart from AFP, it will have better detection. And AFP-L3 can also be added, and other imaging biomarkers in patients who can afford, and if it is available, like abbreviated MRI or contrast-enhanced ultrasound may be added. The third challenge, so far we said that HCC is more common in patients who already have cirrhosis, but nowadays, and in those cirrhotic patients, surveillance is recommended. But nowadays we are seeing a lot of HCC occurring in non-cirrhotic liver. So these patients are patients with NASH with significant fibrosis but no cirrhosis. And many of these patients have got diabetes, and being non-cirrhotic, these are not put under surveillance. And so these patients present with large HCCs because they were not under surveillance. So the solution for this, we should have newer surveillance approaches for these non-cirrhotic livers, and we should first identify these patients of non-cirrhotic liver who should be studied, whether these have high incidence, prevalence of diabetes, how much is the fibrosis in these patients, is obesity or other comorbidities like metabolic syndrome is a factor in developing HCC in these patients. And surveillance approaches in these non-cirrhotic liver should be formulated and incorporated into guidelines. But we should be clear what should be the frequency of surveillance in non-cirrhotic liver. Should it be 6 monthly, 9 monthly, 12 monthly? And will surveillance be cost effective, because we will have huge population with NASH with advanced fibrosis? And what surveillance tools should be employed? To summarize, ladies and gentlemen, HCC surveillance improves survival. We have shown this. All HCC guidelines recommend surveillance. Current recommendation is that we should subject these patients to 6th monthly ultrasound and AFP, and there is an urgent need for adherence to surveillance. But there are significant gaps and challenges in HCC surveillance and early diagnosis. The gaps in cirrhotic population is that there is poor awareness even among doctors, and surveillance tools are not optimal, and even in non-cirrhotic population, their surveillance strategies need to be formulated. Thank you for your patient hearing.
So, it has been a masterly overview of the topic, and it has always been a treat to listen to you. So, a couple of quick questions. What is the role of PET scan in a 1 centimeter lesion? Is there any role of PET scan for surveillance of HCC?
PET scan for surveillance is definitely not recommended. If there's a 1 cc tumor which is already diagnosed by CT with a dynamic CT, triple phase CT scan or MRI, then the role of PET scans comes when we are subjecting these patients for transplant. Then we need to rule out any extrahepatic spread. That time PET scan is recommended. Otherwise, PET scan has got no role in surveillance or in diagnosis.
And what is the screening strategy for patients who are non-cirrhotic and have portal vein thrombosis?
So non-cirrhotic and portal, there's so far non-cirrhotic patient, there's no screening strategy in any of the guidelines. patients who have portal vein thrombosis but whose liver is normal, for example, patients with EHPVO, these patients are not at higher risk for developing HCC, so there's no surveillance guidelines for these.
We are actually late in the schedule is quite late, so no more questions are allowed. If there are any, we can take them in the discussion time.
Thank you.
I request the dignitaries to please felicitate the speaker, sir. Thank you. It's a beautiful evening outside. Please give it a big round of applause for this wonderful presentation. Thank you. I thank the speaker and the chairpersons for being here. Now is the time for the next session, and I am grateful to invite the chairpersons for this session on stage. We have Dr. Rajiv Avasthi, Senior Consultant Physician, past Chairman, API Lucknow Chapter. A big round of applause for sir. Thank you. Dr. Anurag Mishra, Gastroenterologist, Regency Hospital, Lucknow. Dr. Amit Prakash Srivastav, Consultant Gastroenterologist, Lucknow. And Dr. Sudhir Tiwari, Consultant Gastroenterologist from Lucknow. Over to the moderators.
The next talk is by Dr. Kapil Sharma. His topic is evaluating pancreatic head mass. Dr. Kapil Sharma is a senior consultant gastroenterologist in Sarvodaya Hospital, Faridabad. Dr. Kapil, please.
Thanks, Chairperson, for a nice introduction. And I extend my sincere thanks to the UP ISG-CON team, Dr. Sumit and Dr. Puneet for their kind invitation. I will be speaking regarding the evaluation of the pancreatic head lesion in the next 15 minutes. There are so many differential about the pancreatic head lesion. If we are dealing with the pancreatic solid and mixed lesion in the head of the pancreas, pancreatic adenocarcinoma is the one and the common diagnosis. Other close differential are the neuroendocrine tumor, inflammatory mass lesion, autoimmune pancreatitis. Sometimes we can see lymphoma, metastasis, solid pseudoepithelial epithelial neoplasm, pancreatic tuberculosis, and lipoma. The most common cystic lesion which affect the pancreatic head is the pseudocyst, and other common cystic lesion like a serous cyst adenoma which can be found anywhere in the pancreas, IPMN which has a predilection to involve pancreatic head, and we can have a mucinous cyst adenoma which usually involve body and tail of the pancreas but sometimes can involve head of the pancreas. We can have a cystic neuroendocrine tumor, and there are other rare lesions which can affect pancreatic head like a simple cyst and lymphoepithelial cyst and parasitic cyst. Sometimes we can see some mimickers also. Evaluation is entirely different in the solid lesion and cystic lesion. If you talk about the solid lesion, what we will see in our routine practice, the patient comes with the CT scan report. Then we need to answer the few questions like imaging done properly or not, whether any blood investigation can help in differentiating these lesions, whether tissue diagnosis need or not, whether it's needed, to which route you have to take a tissue. And the evaluation of cystic lesion is entirely different. And first step is we need to identify the pancreatic cystic lesion from the pseudocyst. In second step, we usually identify the mucinous versus cystic lesion. And the third step, if the lesion is the mucinous, whether it's a malignant or not. And the mucinous lesion are the mucinous cystic neoplasm and the IPN, which can be main duct, branch duct, or mixed type of IPN. 64 thin slice MDCT with the 3D reconstruction with the pancreatic protocol is the best modality to identify the to evaluate the pancreatic solid lesion in the head of the pancreas. Please don't ask ask your radiologist not to give an oral contrast, because once you give an oral contrast, it can create an artifact which can affect the assessment of the vascular involvement and the surrounding structure. The CT is not useful for the evaluating the cystic lesion. CT is only detect the calcification which can be found mostly in the serous cyst adenoma. Sometimes it can be found in the mucinous cyst. Here you can see the mass lesion on the head of the pancreas which got lightened up during arterial phase, and you can see in delayed phase it got washed out. It turned out to be neuroendocrine tumor of the pancreas. In another lower two image you can see the ill-defined hypodense lesion in the head of the pancreas which is respecting the vascular structure, and the pancreatic duct and other part of the pancreas normal. This turned out to be autoimmune pancreatitis. The pancreatic adenocarcinoma as well as the inflammatory mass lesion in the chronic pancreatitis both have predilection to involve the pancreatic head. Hence, sometimes we find a difficulty in differentiating between these two. In the first image, you can see the well-defined hypodense lesion in the pancreatic head which displays the calcification to the periphery. This is the pancreatic adenocarcinoma. Here you can see the ill-defined mass lesion with the central calcification is turned out to be an inflammatory mass lesion. There are some ancillary imaging feature which can differentiate between the inflammatory mass lesion and pancreatic ductal adenocarcinoma. Like you can see the pancreatic duct traversing through the mass without abrupt cutoff. It suggests this mass lesion is the inflammatory. If you have a side branch dilatation because of traction effect caused by the interstitial fibrosis in the chronic pancreatitis, it suggests of the inflammatory mass lesion. If you see the duct to parenchyma ratio greater than 0.34%, displays calcification to the periphery, double duct sign and vascular assessment and deformity, and the ratio of SMA to SMV greater than 1. It all suggests the pancreatic neoplasm. Role of MRI while evaluating the pancreatic lesion. If you talk about the solid and cystic lesion, it only useful when the lesion is less than 2 centimeter. If you don't find any lesion on the imaging on CT, and it has a no clear-cut advantage over CT. The cystic lesion, it is the very important test to be done. This is the first investigation to be done. It gives a detailed morphology about the cyst. You can identify septa, mural nodule, and you can see the relationship with the pancreatic duct. Although there is sometimes difficulty while differentiating the benign and malignant cyst. In the first image, you can see the hypo-intense lesion on T1 weighted image with not enhanced during the contrast. In the second image, you can see there is a little bit amendments on the periphery. This turned out to be adenocarcinoma. This is the inflammatory mass lesion. In these images, you can see the pancreatic duct which got narrowed. We are not able to see the pancreatic duct in the head. And you can see the peripheral hypointense rim. This turned out to be autoimmune pancreatitis. Role of PET scan. PET scan we don't recommend in the evaluation of pancreatic solid lesion because it has a false positivity in the inflammatory lesion like a tuberculosis and pancreatitis. False negative can be seen in the if tumor is necrotic, mucinous and small. A cystic lesion, there is no role of PET CT. PET CT, here you can see there is the lesion which seen in the pancreatic head got lightened up on PET CT. It turned out to be a neuroendocrine tumor. Here you can see the calcification is there in defined mass lesion on PET CT. You can see the lighten up. It turned out to be malignant. Role of blood marker in evaluating a pancreatic solid lesion. Role of CA 19.9 had a sensitivity of 80% and 90% specificity for evaluating the pancreatic cancer. Although it has some limitation like it can be false negative in the small tumor, and 5 to 10% cases where the Lewis antigen not expressed, it can be negative. It can be elevated in autoimmune pancreatitis and inflammatory mass, and sometimes it can be elevated in presence of obstructive jaundice. Chromogranin A and NSC can help to diagnose neuroendocrine tumor, and IgG4 can be elevated in autoimmune pancreatitis. Sometimes it can be elevated in pancreatic cancer. It can be noble in type 2 autoimmune pancreatitis, and it has a low discriminating value. No blood marker can differentiate between the cystic lesion. Sometimes if you have a high amylase and lipid which can differentiate between the pseudocyst and other pancreatic cystic lesion. The endosonography or EUS, it is the only tool which has a good sensitivity specific for both solid and mixed and cystic pancreatic head lesion. It gives a detailed morphology about the cystic and solid lesion. and it give a assessment of vascular and lymph node in very good manner, and diagnosis accuracy can increase by the FNA and FNB, and it can stage the tumor. And US and ERCP can be done in the same sitting. If a lesion is unresectable, we can do celiac plexus neurolysis. And the US is the ideal tool for the cystic lesion. You can see the mural nodule, septa, and the relationship the pancreatic duct can be done easily. It has been always a matter of debate whether once you see the resectable mass, whether you need a tissue or not. Gastroenterologists are the for taking a biopsy, and the surgeons are against the taking biopsy, because biopsy is the safe and cost-effective method, and it is improve the staging. Sometimes the small percentage of the patient have a benign disease whom surgery done was unnecessarily. It gives a psychological and tactical benefit for the both patient and surgeon if malignancy confirmed preoperatively. Regarding the negative predictive value is 55%, it doesn't change the treatment plan, and some surgeons say the diagnostic lab followed by the resection is the better staging modality. Sometimes small but real risk of biopsy related complication could delay the treatment. My approach is the US followed by the US FNA. Biopsy could turn out to be negative, then you have to do core biopsy or either surgery. There are some video which suggest, in the first video you can see the pancreatic lesion in the head of the pancreas with the abutment of the superior mesenteric artery. This turned out to be pancreatic adenocarcinoma. In another video you can see the lesion which respecting the vascular structure. This turned out to be neuroendocrine tumor. Here you can see the ill-defined pancreatic lesion. This turned out to be autoimmune pancreatitis. Here you can see lesion with the multiseptate with the solid component. This turned out to be a mucinous cystic neoplasia. Now here you can see some pancreatic lesion with the solid component with a small cystic component. Once you taken a FNAC from the both solid and cystic lesion, and this turned out to be a SPAN, solid pseudopapillary neoplasm. Here you can see in the pancreas multicystic lesion. Here you can see the pancreatic ducts. There was no communication with the pancreatic duct. In another video, you can clearly see the pancreatic duct communicating with these cystic lesions. Here you can see the communication between the pancreatic duct. This is the side branch IPMN. Regarding the role of US elastography and contrast US elastography has a sensitivity especially to 100%, because the normal pancreas and inflammatory mass and the carcinoma pancreas, they have the different strain ratio. Higher strain ratio suggests the malignant pathology. Regarding the contrast US, because the malignancy, you can have irregular appearance of the arterial vessel over a short distance. You don't see any venous vessel inside the lesion if you are suspecting the malignancy. Sometimes you can have a interventional, once you had a head lesion, it can compress the duodenum, and then patient had a feature of gastric outlet obstruction. Then what you can do US guided drainage. Here you can see that this intestine got punctured by the hot exhaust stent, and subsequently US GJ was then here you can see the US GJ was done. Once you got a biliary obstruction, presence of biliary obstruction, you can do choledochoduodenostomy. The rare pancreatic lesions, sometimes you see hypointense lesion in the pancreatic head, which is a very low attenuation value. It turned out to be a pancreatic lipoma. Here you can see the pancreatic duct dilated after the Pusto surgery, which mimics the pancreatic cystic lesion. Now you can see the annular pancreas, which mimics the pancreatic mass. The take-home message is, once you have a solid and mixed lesion, CT with the pancreatic protocol, US with FNA help to establish the diagnosis. Sometimes it's very difficult to differentiate between the carcinoma pancreas and chronic pancreatitis. Negative biopsy, once you are suspecting the pancreatic mass, you should go for surgical exploration. CA 19.9, good biomarker, but has some limitation. And the cystic pancreatic lesion, you should go for MRI with MRCP better than CT. US give us some additional information. You can easily differentiate between the mucinous and non-mucinous by the cystic fluid analysis. MPD diameter greater than 10 mm, mural nodule, presence of obstructive jaundice, enhancement of solid component enhancement, and the high CA suggests it's a malignant pathology. and you should follow these lesions by their size and annual growth. At the end, I extend my sincere thanks for your patience hearing, and I will be happy to answer any question.
And I request the chairperson.
May I ask one question if there is a time, if chair permits? So what would be the telltale signs to the physicians when to suspect the pancreatic tumor?
If patient has obstructive jaundice, significant pain, then weight loss, then you can suspect a pancreatic. In presence of obstructive jaundice, significant pain and weight loss and loss of appetite, you can suspect a pancreatic. What we usually we see patient come with the imaging, whether they have ultrasound done or CT done, and then come to us and then we'll try to evaluate the lesion.
And what would be the first investigation you advise?
For the solid lesion, I will say CT with the pancreatic protocol is the first test. For the cystic lesion, MRI with MRCP.
Thank you. Thank you.
One thing more, there is new drugs are coming in oncology of GI. As we know that in colon cancer we are using, I think, PD-1 inhibitor. As any role is there is any role of PD-1 inhibitor in cancer of pancreas?
I don't think there is a role of PD-1 agonist in the pancreatic cancer. Their role is mainly in the hepatocellular carcinoma.
Okay.
Thanks for the presentation, sir. I request the chairperson and the moderator to please felicitate our speaker, Dr. Kapil Sharma. A round of applause, please. And with this, we come to the end of this session. And the last talk that we are going to have is the last topic. And for that, I invite the chairpersons, Dr. Rahul Yadav, Consultant Gastroenterologist, Lucknow, Dr. Jagindra Shukla, Consultant Gastroenterologist, Apollo Medics, Lucknow, Dr. Piyush Mishra, Assistant Professor, Department of Gastroenterology, Medicine, SGPG IMS, Lucknow, and Dr. Rajiv Pant, Consultant Radiation Oncologist, Lucknow Cancer Institute. Over to the moderators.
The last talk of day one is by none other than Professor V.S. Saraswat sir, who was former Director Professor and Head of Department, SGPGI Lucknow Gastroenterology Department, and now he is heading the Department of Gastroenterology at Mahatma Gandhi Medical College, Jaipur. Over to Professor Saraswat sir, please. The topic is systemic therapy in hepatocellular carcinoma. What is new?
Thank you, Dinesh. Thank you, chairpersons. Good evening, ladies and gentlemen. At the outset, I can see Puneet and Sumit sitting there. I'd like to give them a special thanks for inviting me to Lucknow, where I've spent the best part of my life, over 33 years at SGPGI. And coming back here on the occasion of a UPISG is feels very good for me. I am going to talk to you in the next 15 minutes or so about systemic therapy for advanced unresectable hepatocellular carcinoma. What are the new developments in this area? I think you heard Ashish talk a short while ago about the fact that HCC is increasing in our country, particularly in the northern and western parts. And I think most of us who are dealing with HCC would know that we are increasingly seeing large tumors with extensive vascular invasion and spread, that is advanced unresectable HCC. And in the last decade or so, there have been major advances in the management of advanced unresectable HCC. So I'd like to cover these points here. Now, what exactly do we mean when we talk about advanced hepatocellular carcinoma? This is the 2022 update of the BCLC classification for HCC, which we are all familiar with. And in this, they've graded HCC from grade 0, A, B, C, and D, and advanced refers to grade C, where there is portal invasion and extrahepatic spread. And according to the BCLC algorithm, the therapy they suggest here is the use of systemic therapy, while the loco-regional therapies are reserved for intermediate grades of HCC. Here in this guideline, they have talked about the first line, second line, and the third line therapies for HCC, which I won't go into detail here. However, Ashish spoke about the 2014 and 2019. I think he's again led the nasal modification of the BCLC score as a part of the 2023 nasal recommendations for HCC. BCLC is the standard classification followed globally, and there were several lacunae and deficiencies which have been addressed by the INASL. In fact, each of the categories of A, B, C, and D have been broken up into A1, A2, B1, B2, B3, C1, C2, D1, D2, and the corresponding treatment allocation as well as therapies for them have been revised. So we are concerned here with advanced HCC, which is C1 refers to when portal vein invasion is present without any extrahepatic spread, while stage C2 is extrahepatic spread, which may or may not include portal vein thrombosis. And in addition, or before resorting to systemic therapy, the use of TARE, stereotactic body radiotherapy, or resection if feasible is also considered part of the treatment, in addition to which systemic therapy or systemic therapy alone may be resorted to in the advanced HCCs. So this is what we mean by advanced HCC. Now, what are the systemic therapies we have for HCC? Well, the systemic therapies that you would all be familiar with are the various forms of immunotherapy. I think one of the chair moderators was just referring to it a short while ago. And the various immunotherapies or immune checkpoint inhibitors which have been used extensively in oncology, in breast cancer and other tumors and have been applied to HCC include the multi-tyrosine kinase inhibitors. The very first one was sorafenib, and lately lenvatinib is being used as first-line therapy, along with the other molecules that you see listed here as second-line: cabozantinib, regorafenib, ramucirumab. Anti-PD-1 program DEath1 and anti-PD-L ligand 1 receptors, of which the most notable is atezolizumab, which I'll be talking about more extensively in my talk. Others, nivolumab, pembrolizumab, sintilimab is a biosimilar with the anti-PD-1 agent. Durvalumab and all these other agents have come up in a big way. They are now available. The cytotoxic T lymphocyte antigen 4 inhibitors, CTLA4 inhibitors, tremelimumab and ipilimumab have come up. And of course, we have the anti-VEGFR molecules, bevacizumab, rivoceranib, and the others. Now, as you can see, in the last 10 to 15 years, a host of molecules have become available for advanced HCC. And how do we use them? Monotherapy, combinations, etc. So various permutations, combinations have been possible. And again, in this JCH 2023 review, which is there online and is just coming out in print, this summarizes recent trials of what have been used, the first-line systemic therapies for advanced unresectable HCC. And of these, the best known is the IMBRAVE 150 trial, in which atezolizumab was, following which trial it became the first choice therapy, first-line therapy for HCC. The Himalaya trial has just come out with durvalumab and tremelimumab. Cosmic 312, Checkmate 459 about nivolumab, cabozantinib and atezolizumab. These are the few first-line agents that have been published in the last few years. And they really give you very impressive results in disseminated disease, which is extrahepatic spread with vascular spread. Well, you have, when the IMBRAVE 150 trial was completed, at that point when it came out in NEJM, the median survival point had not been reached. Well, an updated version of the IMBRAVE 150 trial, I'll be referring to briefly here, has come out in 2022, in which they have found that the median overall survival has gone up to as much as 19.2 months, with progression-free survival for close to 7 months, and more than a quarter of the patients have an objective response rate. The other combinations give you similar median overall survivals, although the PFS, the progression-free survival, is best with the atezolizumab combination, atezolizumab combination. So a lot of therapies, systemic therapies have now become available, and in fact in this table, a recent publication from JAMA Oncology, what they have done is that the European Society of Medical Oncology has actually developed a magnitude of clinical benefit scale. Most studies give you statistical results, there's significant benefit and so on. Yes, lately these trials have given significant, very impressive survivals, but this scale, that is the magnitude of clinical benefit scale, has been graded from scale 1 to 5, and these two drugs, the atezolizumab plus bevacizumab, atezo-bev for short, as well as its biosimilar combination which was published from China, sintilimab and IBI 305, gives substantial benefit, maximum benefit in terms of clinical advantage to the patient. The SHARP trial, the RESOURCE trial in which regorafenib was used, and then this other combination of PDL1 with VGFR agonist, all have given substantial benefit, while the other combinations although give lesser benefit. So as of now, a variety of systemic therapy options are available for patients with HCC, and amongst these, which ones should we choose? So I'll be talking mainly about the best studied combination and the one with the most results are available, and that is atezolizumab plus bevacizumab. This is the NEJM trial in 2020, following which this was licensed as the first-line therapy after sorafenib and lenvatinib. Recently in the JHEP, we have the 2022 version in which the update of IMBRAVE 150 has come out, and I'll refer to it in the meta-analysis. Various society guidelines are available, and systemic therapy for HCC has become such a hot area that almost every major society, liver society as well as oncology society, in the last 3 or 4 years have come out with fresh guidelines, mainly centered around systemic therapy for HCC. And the most recent of which, led by Ashish, is the 2023 update of the INAZL consensus, the PURI 3 recommendations. And most of them, the gist is very similar, so I will not be talking about the others in detail. I will only take you through what the INAZL 2023 tells us about systemic therapy for advanced HCC. And first-line therapy, they say, is atezo-bev, for which there is a high level and a strong recommendation. For any reason, generally financial reasons, because this is an expensive combination, or if a patient has some contraindication to immunotherapy, lenvatinib or sorafenib are recommended as first-line therapy. And after the Himalaya trial that has come out, tremelimumab plus durvalumab is also an equally good option as first-line therapy, but unfortunately this combination is not as yet available in our country. The others deal with second-line options for atezo-bev failures or lenva failures, and I won't go through all this detail for lack of time. So a quick look at what we should do. Advanced HCC, BCLC C1 or C2, or even BCLC-B, where loco-regional therapies have not worked or the disease has progressed or are contraindicated, are candidates for systemic therapy. And should they be offered immunotherapy versus multi-tyrosine kinase inhibitors? Well, most studies favor that if the patient is a candidate, the contraindications like autoimmune diseases like liver transplant recipient or other conditions where immunotherapy cannot be considered, if they are ruled out, then most guidelines recommend that atezolizumab should be used first. And if in a disease progresses with them, then you move on to the second-line combinations. While if the person is not a candidate for immunotherapy, you would straight away go to multi-tyrosine kinase inhibitors and leaving the immunotherapies out of this. Now, what is the real-world experience with atezolizumab in the last, and this all refers to the last 3 or 4 years only? Recently, the first Indian experience with the safety and efficacy of atezolizumab was published in the in our liver journal, the JCH, which is basically a group of patients treated in Hyderabad AIG, and we also had a small numbers from the Mahatma Gandhi Hospital in Jaipur as a part of this study. 67 patients, mainly men, 3/4 of them BCLCC, over half NASH HCC, who were unresectable HCC, were treated with this combination, and most of them were A and B. Since there was no specific contraindication to C in the early part of our experience, we included a small number of CTP-C patients also, but I'll just come to the very poor results in them, which really rules out the use of this combination in BCLCC patients. Had a median overall survival of about 12 months, with the progression-free survival was 8 months. 40% had an objective response rate, and disease control rate was as seen in almost 2/3 of these patients. Now, complete response, that is when you assess at 6 months, the tumor has disappeared. You are talking of a tumor that has invaded the portal vein, is a large lesion in the liver with extrahepatic spread, and the tumor is no longer found. There is a complete response was seen in about 13% of our patients. Our numbers are small, but the numbers were about 13 of our patients. Similar in CTP A and B. Partial response was seen in about 1/4 of the patients. Similar in CTP A and B, and so the objective response was close to 40%. Stable disease that did not progress or did not regress was seen in another 27%, but here somewhat better for CTP A than CTP B patients, and disease control rate was 80% overall in CTP A versus 70% in CTP B. Progressive disease was invariably seen but was lesser in CTP A, and was always seen in our CTP-C. The small numbers, all of them progressed. And so overall, the real world experience that we found that we could implement in India was comparable to what we saw in the licensing or the registry trials. Similarly, a very large study from North America and Europe, again 216 patients, 11 centers, viral etiology in over half, showed a similar good overall survival of about 15 months, with 7 months of progression-free survival, and only about 1/4 had severe adverse events. So atezolizumab, again in other parts of the world, also performed very well. And recently the Hyderabad group have carried out a systematic review and a meta-analysis of all the published experience with atezolizumab, including, this includes one of my colleagues working with me in Mahatma Gandhi. So over 5,400 patients in 47 studies, viral etiology in 60%, showed that the pooled overall survival was quite good, comparable to registry trials at about 14 months, 7 months progression-free survival, and looking at the M-RECIST, the overall response rate was seen in 1/3 of patients, and disease control rate in over 3/4 of the patients. Side effects were similar, about 32% as in real life, compared to about 25% in the registry trials. Interestingly, atezolizumab performed better than tyrosine kinase inhibitors with a better overall response rate and longer progression-free survival. It performed equally well in CTP-B and CTP-A, except that the progression-free survival, the time to progression of disease, was a bit less in CTP-B, and as first line versus second line therapy. So overall, as this study shows here, these numbers again recap the same what I've said. Our study from India, the first Indian experience, the North American and European experience, and the meta-analysis give you numbers which are close to the registry trial updated in 2022, 14 months, 15 months, because of the CTP-C, our group had a slightly lower overall survival rates, and so this combination definitely appears to be fairly promising. But nevertheless, what you find is that the overall response, response rate here is around 40%. So 60% of people do not respond, and generally takes 3 to 6 cycles to decide that they are not responding. And using an expensive combination, this is a lot of money. So can we predict which patients will respond to atezolizumab? Well, whatever data are available, neutrophil lymphocyte ratio, the CRAFITI is a new score that has come out using CRP and alpha-fetoprotein in immunotherapy, showing that low levels of alpha-fetoprotein and C-reactive protein less than 10 milligrams predict a good response to immunotherapy. Similarly, after a decline in AFP at the end of the first round of 3 cycles at 3 to 6 weeks gives you a good idea who's going to respond and tumor is going to regress. Other things like PD-L1 expression are not very useful, but the hot tumor in which there are tumor infiltrating lymphocytes show CD274 and CD8 positive T cells on histology, again predict a very good response. On the other hand, histology, if it shows a high Treg to T effector cell ratio within the tumor tissue and expression of oncofetal antigens, they will not do well against with using immunotherapy. Adverse immune effects with immunotherapy, I think I'll just take you quickly through. The unique adverse event that you have is immune-mediated liver injury caused by immune checkpoint inhibitors or ILI-CI. Uncommon, more when you use, it's less than 2.5% will have severe injury and only 1 in 200 will have grade 4 injury manifested by deranged LFT during therapy, and it mimics AIH or DILI. So can be graded from grade 1 to 5, and in the early grades, what you do is withhold immune checkpoint inhibitors and use steroids for about 4 weeks, with which if there's a response, that's great. But otherwise for grade 3, grade 4, you withhold and you're not able to reintroduce immune checkpoint inhibitors. Finally, last couple of slides on where are we headed with in systemic therapy. You have effective therapies. Why not use effective therapies in combination along with loco-regional therapies? So there are several trials that are currently recruiting in this combination, and our center is also recruiting patients for the Emerald 3 trial, in which durvalumab and tremelimumab along with lenvatinib and TACE are being studied, a combination of immunotherapy, TKIs and loco-regional therapies versus TACE alone. These are the inclusion criteria which I will not dwell upon. So one group is receiving combination of tremelimumab, a single dose, followed by durvalumab daily for 4 weeks, and day 1 and then at 4 weekly intervals, lenvatinib and TACE. Second group is durva tremeli with TACE, and the third group is TACE. They're going to follow this study for 3 years, and it's a multinational, multicentric study sponsored by a leading multinational, results of which are awaited with great interest. There do remain a few unanswered questions in the context of systemic therapy for advanced HCC. Firstly, how do you choose, now that you have so many therapies, which ones? So some preliminary answers about pointers to who will respond to immunotherapy versus who will respond to TKIs. Some people felt that etiology may be important. Answers are evolving. There is no clear cut. Here today, basically what happens is what people can afford. Cost dictates. Most importantly, predictors of response, who will get that rare mirage of a complete response in advanced HCC, what is their characteristics, is something which is generating intense interest, and I think histologic data are preliminary, but we are very far from a clinical biomarker that will tell us. Again, duration of therapy after response, if a patient responds, how long to continue therapy, will the tumor come back if therapy is stopped, can we do an liver transplant in these patients? You know, immunotherapy, immunosuppression are direct opposites. So a person on immunotherapy, you have to give a gap before you transplant him and then immunosuppress him. And immunotherapy doesn't work very well. Finally, personalized therapy, CAR T-cell therapy is the chimeric alloantigen receptor therapy, which is the buzzword now in oncology. Work is coming in for HCC as well. Well, thank you very much for your attention.
Thank you, sir, for such a wonderful talk. We can allow only a couple of quick questions because we are way behind the schedule, if there are any. Yeah.
Hello, yeah. So in early Yardle, where peripheral portal vein branches are involved and the AFP level is low, many transplant centers have done liver transplant with a survival rate of more than 60 to 70%. So even as per your description, the classification says that when the portal vein, peripheral portal vein is considered advanced. But I think I'm a transplant surgeon, so in our group, in our community, transplant for peripheral invasion is yielding very good result. So I want your comments on that.
That's a good question. See, the staging doesn't change with what modality of therapy you offer. Instead of the Yerdle now, it's the VP4, VP1, 2, 3, 4 that you use, main portal vein being VP4 and then VP2, VP3. VP4, and in all of these, I think Soin and the Medanta group have leading work and they are published, but nobody operates on them upfront now. You always downstage them with using various treatment modalities. A combination of SBRT, TARE or other ablative therapies are given, in one successful downsizing and tumor does not reappear over 3 months, then they go in for transplant.
Yes.
And they're giving results which are comparable or close to what you would get in early HCC.
Yes.
So in advanced HCC, particularly with peripheral portal vein involvement, there is a place for liver transplant. But again, you will agree that this is not universal, this is not the rule that every transplant center follows.
Yes,
the ones who are following this, do this following aggressive therapy for the portal venous infiltration invasion, and certainly not for extrahepatic spread,
Yes, never.
which is where systemic therapy is at least among the responders, CR, PR, PFS, I mean the ORR groups, you get very good survival in people who otherwise had 3 to 6 months to live. What you talk about BCLCD is best supportive care, 3 months of life.
Right.
So there, if you get a response, that is something that is worth striving for.
Thank you.
If there are no more questions, I request Professor Saraswat to remain on the stage, please, for the felicitation.
Thank you, sir. I request you to please be there on stage and request the chairpersons and moderators to kindly felicitate our speaker, Dr. V.A. Saraswat. And let us join our hands for this felicitation. A part of Lucknow with you, sir. Thank you. Thank you. And a quick announcement by the organizing chairman.
Gala dinner and musical evening would be in the same hall, 8:30 p.m. onwards. 8 p.m. onwards. Sumit keh raha tha. Where is Dr. Alok Mishra? Alok Mishra is going to present secretary report without a report. Thank you, ma'am. Thank you so much. अब आप स्लाइड में दिखाओ क्या? अरे मान जा रहा है। मैं स्लाइड में दिखाओ। नहीं, ठीक है मैम। सरकार डॉक्टर स्लाइड में क्या बनाना है तो क्या लाए हो? जीवन का एजेंडा। ये पूरा ये कुछ एजेंडा है पक्का एजेंडा है ये आदमी रुक नहीं सकता
Good evening. I will request all of members to please be seated. We have a long-awaited GVM of UPISG, which is almost 2 to 3 years we have not met as a GVM because of COVID, and after that there is a Now we are formally having a formal GVM today evening, and we request all of you, those who are behind can come forward and take the seats. And before the starting the GVM, finally, I request our immediate past president, Dr. Ghoshal. Sir. And Dr. Arun Khanduri, President, and Dr. Alok Gupta, President Treasurer. We had this executive body made hurriedly last year, when COVID was over, and so now we are having meeting for the first time as an organized. Dr. Alok, can you come? It was made. That was made, that's why you were made the organizing secretary. So now, as a body, national body has made several recommendations. First of thing, agenda of today is to adoption of national body constitution or bylaws to the state chapter as a bit mandatory from national body. And I think I have requested Dr. Nijavan to be here as a national body representative. Can somebody call Dr. Nijavan? And we have election of new governing council, that means all the members executive body, and the next is venue of next year annual conference. As you know, we are having next year a national conference at the Varanasi BHU with Dr. V.K. Dixit is the organizing chairman, and we must congratulate him that national conference is coming to UP, and we must make a sincere effort to make it a grand success. As we know, UPISG was formed in 1988, and Professor Sahi from KGMC was the first president of it. And after that, society has grown from its infancy to this status. As per national body constitution, there is a life member, honorary life member, and any other type of members. So in our state chapter also we should have life member or any other type of member, as GVM decides. Governing council says in national body, you should have immediate past president. Our immediate past president was Dr. Ghoshal. President was the president-elect, secretary, treasurer, and governing council member 6. Because of last year turbulence, we could not have fully governing council, but for the sake of having some society so that we can bid for state chapter, national chapter, and we can organize a state chapter in BHU. So we have made a hurriedly executive body. So Dr. Khanduri, myself, and Dr. Alok Gupta was elected, nominated, whatever you can say, it was there. Another thing is what national body says, funds and assets to the society. National body decides funds from membership fees, contribution from national and state chapter conferences, and donation whatever if they receives. And similar, we have to adopt this method. So now we have governing council where we have to have president-elect, and the national body tenure is only 1 year. And after 1 year of tenure, president-elect will automatically be a president. Tenure of president is 1 year. Eligibility of president is at least 3 years as governing council member. But as we are having fresh governing council, we cannot adopt this rider that anybody who has been a 3 years governing council member will be elected for president. So this we have to make relaxation. Gaurav, can you give me? Yeah. No, that back.
They are constitution bylaws, national body, and you can go through it. There are a few copies. Just 15 minutes more. 15. And similarly, secretary, there are tenure for 3 years, but it can take 2 terms, not beyond that. That means any secretary cannot hold office for more than 6 years. And again, the rider is at least 3 years as governing council member. So again, this year we have to relax this. Treasurer, same as secretary. Now the point is to elect 6 governing council members this year, but 2 members will retire every year. So every year 2 new members and 2 members will retire, and so 1 member should have at least not more than 3 years tenure. But today, if you elect 6 people, 2 voluntary should retire, so that next year we'll induct 2 more. So for first 3 years, it will be voluntary retirement other than as a rotation. The national body says the state chapter has to be formed as per national guidelines, and for holding a national conference, a local organizing committee should sign a memorandum of understanding with secretary of the society. Similarly, if we have state chapter UPIGCON in different cities, there should be a local organizing committee duly formed, and it should bid and it should sign a memorandum with the state chapters. A percentage of the registration amount or any other amount fixed from time to time by governing council will be paid to the society. So that, like if a national body and state chapter have MOU, the state chapter have to pay some fixed amount to the national body to hold the national conference. Similarly, if a local city who is organizing a UPIGCON, there should be minimum amount they should pay to the state chapter. So that state chapter should have some funds to run its secretariat and to maintain its activities. You know, the Tamil Nadu state chapter is having corpus of 1 crore. It was astonishing. And UP, for since 1988, it's almost 0, every year 0. So now we have to go ahead with a structured formation of a society. Financial implication of what the national body has proposed, that after every conference there should be a profit sharing. Whatever profit is there, 60% go to national body, 30% to state chapter, and 10% it will go to journal. Similarly, if some city holds the UP chapter, some amount should go to state body, some amount should be with the who has organized, and some amount should be reserved for as an big corpus for further academic activities. Because as society will progress, we will have our academic activities round the year. An audit of the conference within 6 to 9 months. This is the recommendation of national body, and we have to similarly adopt in a state chapter also. So in this GVM, the proposal is we have to adopt the bylaws which are mandatory, this is proposal, but as per national body, these are mandatory to adopt with state chapter if they have legalized state chapter. And after that, a new permanent account should be opened and permanent office address to be mentioned in the registrar of the office. For UPIGCON, local organizing committee will function in coordination with the state chapter, and they should use my proposal that if there is a city which is organizing, it should have its committee duly formed and should have its PAN so that it has its finances. And certain amount will go to the state chapter. Right? And of course, we have 180 DM gastroenterologists in UP. I have the number also, and most of them, their numbers are not updated, mail is not updated, and we don't have any registry, we don't have any registration fees. It is absolutely in disarray. Because of the 2 years COVID, everything was lost.
So we have to restart. We start with the membership fees, life member, and now GBM has to decide what should be a life member fees so that we can have our society running and we will have life member duly registered with a name.
I think we can take each point. Number one, I think we can ask the GBM and we can do it by show of hands, whether we have adopted the national bylaws and we will follow that. I think that is the easiest question, and we have to.
Okay.
So we have adopted that proposal of this. Now, the next was, I think we'll, fees. So we'll go with this like this, then we'll come to the election. So,
Life member fees and-
Alok, what is the life member fees in ISG, a national body?
25,000.
So,
सर अभी जो देखिए उसमें शायद लिखा हुआ जो अभी मैं सर्कुलेट किया है, इसमें देखिए शायद 25,000 लिखा। हाँ, ये तो ये फीस पे ये हमारा वो नहीं बाइंडिंग कि नेशनल बॉडी की आप इतनी रखोगे।
15,000 plus GST. Life membership.
Life membership.
UP chapter. See, we'll have to pay to the national because see, the proposal was that all the people first you register to UP chapter, and then you have to we will send the proposal, and you will be registered for the national chapter also. So the fees has to be sort of.
No,
made.
but only thing is try to understand. As per law, you cannot collect GST if you do not have GST number. So if you want UPISG to have GST number, you can collect GST. But if UPISG doesn't have GST number, you cannot collect. Second is, if you have GST number, you have to file return every month, irrespective of whether you collect money or not, every month. So it is better that if you think so much commitment will be difficult at this stage, don't have a GST number, but then don't take the GST.
So that should be a fixed amount that should be levied.
They had proposed that if you take the fees, then we can that member should automatically register to the Indian society also.
That's can somebody call Dr. Nijavan? Okay.
No. He has to be a member of the national ISG and then the member of UPISG both. You can't be that you are a member of a local society, state society. You are a member of the state society and you are not a member of a national or otherwise. So they are trying to streamline everything. They are trying to streamline because this time when we attended the meeting, the national body was very stringent. They wanted that we should adopt this and function in a proper manner, just like the national. So that is why we are sort of going into a formal. Obviously, we'll talk semi-formal. We'll take decision, but that is what they want. So how that can go about is a thing. We will discuss that.
I think as GBM sentiments is there, 15,000 we will keep it, and if we can manage with this national body, well and good. If with after discussion with national body, if we have to raise it, then we will raise it. No, GST not mandatory. Until unless you provide the services, the national body might be having the GST number, no?
Because national body, it has GST number because national body obviously have lot of collections, and if you have huge collection, you cannot operate without GST. So our national body has a GST number, journal has another GST number. So we have two GST number which are separate, and they cannot operate without GST number because immediately they will be penalized. When you have a small amount of money in any society, GST may not be mandatory. ऐसे कुछ नहीं है. उसमें क्या कहते हैं, जे suppose government is little relaxed now, that what it does is that normally if you ask any company to pay money, they will ask you a certificate. In certificate says, since we do not provide any service, do not sell any good, hence we do not have GST number. Now what the company will do, because they have GST number, they will pay you the amount, and the reciprocal amount they will pay to the government directly without paying you. But if you take GST number, then you will get the company paying GST to you. Now that GST within 30 days you have to pay to the government. And the government will now in return give some amount of money as a credit. It will not come as a money, it will come as a credit to our account. So there is a constant this circle going on which is making the black money less, parallel amount of money less. This is current system.
So, अगर आ जाता है तो
you see, no, but
we
try
will
to-
start and later on after 2-3 years.
try to understand.
We can always
Tamil Nadu-
start later. GST number can always be started. I think 15,000 without sort of taxes, a round figure would be good. And then we will negotiate with the national body. We would like that if a member is here, some amount may be paid to the national body to register there also. And we have a sort of...
No. System is that you cannot make anybody local society member if he or she is not a national member.
I agree.
So try to understand, that means he has to pay 25,000 to the national and the 15,000 to local, that means he has to pay 40,000 rupees to become member of both. And he has to be mandatorily a member of national society. Let us hope all the members who will be state chapter member are already national member.
So that we will clarify with the national body. Till that we will keep it at 15,000, and if communication, if something is contrary comes, we will inform the GBM. And of course, please update your
Dr.
contact.
Puneet, you're trying to tell something?
Puneet is trying to do hurry up so that he can prepare for.
Okay, so just hang on for a moment. We'll. Okay, so now I think
you
we can
start booze and
you can start
GBM will increase.
the honors. Start the honors. Dr. V.K. Mishra is waiting for the honors to start, sir.
So currently we have election for President-elect, President, Secretary, Treasurer and Governing Council member. Please raise.
So this time I think we have to have President and President-elect both. Because I have already completed the tenure and there will be, but we hadn't had the President-elect because of the vote. So now we have to elect both the President and the President-elect in this. So any proposal for...
Somebody wants to come forward voluntarily, somebody wants to propose name, at least two names, Vice President and President-elect.
Dr. V.K. Mishra?
Yeah.
Achha, you were President already.
So,
Dr. V.K. Dixit,
sir, तो हो चुके हैं.
You've already been there. No?
Dr. Malay? As President or President-elect?
President.
Okay, Dr.
So, GPM, you can show by raise of hand, Dr. Malay actually is the only proposal also. So he is the next incoming president, and a very good round of applause.
And one name for President-elect?
So,
President-elect.
Puneet. Yes. Elect.
So now you are serious President-elect?
Yes.
Okay.
Yeah.
There's no other contender?
Dr. Puneet.
Yeah, no other.
Another is?
So Dr. Malay Sharma is President for this year, and after that Dr. Puneet will take over as President, President-elect. Secretary and Treasurer,
No, president-elect he is. Automatically
He will take over as the president, yes.
Next year.
Next year.
next, he will take over next year.
Automatically he takes after the tenure of Dr. Malay.
Secretary and Treasurer,
So you have already completed, I think, 1 year.
1 year.
1 year. So you continue for secretary for 3 years, you have the tenure. You have the tenure for 3 years, so we can say that he continues as secretary for 2 years. नहीं, अभी
And Dr. Alok Gupta was treasurer.
Stop. Dr. Alok Gupta, treasurer. So actually.
So let him continue because they have only been 1 year. We have formed the society again.
Yeah, no problem.
So they have the tenure for 2 years. So we can let the secretary and the treasurer continue. We have already elected. So now the council members.
Governing council member, we should have 6 members, and preferably they should be from the different part of the UP so that we can have representation from all over the UP.
Dr. Sumit Rumta.
Second him.
Dr. Praveer. Dr. Praveer Rai.
From BHU he can be the member.
Dr. Dinesh from BHU.
3 more from the western part of the UP.
Yeah, Dr. Kejriwal. Dr. Kejriwal.
Dr. Kejriwal.
Dr. Kejriwal. Dr. Dinesh. We have 1 more.
5 हो गए.
Sir,
Gaurav is there.
सर आप लोगों ने एक नई क्योंकि नेशनल सोसाइटी से इन्फॉर्म हुआ कि उत्तराखंड ने So you are with us or we are with the UK society? So you will represent UP?
No.
UP occupied UK?
No, but what do you want? What do you want? No, then you see, if the national society is telling that, you can always tell it is too premature now to make a separate society. They already made. Are you already made? Okay, then no problem. Then no problem.
I think 6th name, Dr. Gaurav Chawla, how about that? 6th name is left or we have already completed a 6th governing council?
6th name.
Dr. Gaurav Chawla, I would propose if.
No, because try to understand, the problem is, whatever it may be, UP is a big state, but still somehow ISG of UP did not perform too well compared to many other small state. Now at this stage, without taking this forward together, UP and UK, suddenly you make 2 societies, it is not easy to grow. Because if it was already like Tamil Nadu or Kerala, then it was fine. You can say UK separate हो गया. But ये अभी कुछ ज़्यादा किया ही नहीं UP society. Now you make 2, is difficult to grow.
So can we sort of have the conferences together because he is already registered, so we can
Have the conferences together.
Under bylaws, if Dr. P.K. was not allowed as a member, we can have a co-opted adopted member?
No, there is no system in the bylaws that he cannot be a member, no?
If he can be member, he can be a governing council member also.
Yeah, that's right. In fact, this should be.
But governing, first thing is that you are organizing conference, that is the point of your inducting as a governing. So governing will have to see also because he is registered a society in his name. He's already sort of got president and they have all been registered there. He's already the president of the society.
Oh, you are already president. Okay. Okay, then co-opted member will be better. Yeah, that's right.
गौरव को 6th वो प्रपोज कर देते हैं आलोक
और इनको co-opted कर दीजिए.
We will co-opt you. So we will make you UP occupied UK, Pak occupied Kashmir. But
we have the 6 members, I think, of the governing council. So
work the next year UPIG Con, and one thing is we have to fix it month at least, so that everybody knows कि इस month में UPIG Con होनी, जैसे national body पता है नवंबर दिसंबर.
See this.
Mike.
No,
Mike, I think I have to speak.
This is not working. Yes. So, I think, so we had to shift to March, and this is an opportune moment to shift to March because November we will be having the national. We don't want to clash the date with October and November there. So, one thing is that we are proposing it to be in March.
Dr. Malay,
So, Dr. P.K. Agarwal has said Mussoorie, Dr. Malay Meerut, and Dr. V.K. Mishra is obviously there, and Gorakhpur, yes. 4, so we have already got 4 conferences ready. 4 annual conference this year?
हाँ इसीलिए तो तुम तो जीवीएम कराने नहीं दे रहे थे.
Region? Okay.
नहीं सर, आपका और डॉक्टर पीके का. Sir, Dr. Malay, Dr. PK has some proposal for you.
We tried the workshop this time. I had asked Puneet and he tried the logistics, but Dr. Praveer also was sort of,
So it's basically cut short. We have 2 proposals from Dr. PK and Dr. Malay, and GVM has to decide.
No, there are 2, there are 3 proposals, 4 proposals, 5.
No, one
Third is Gorakhpur also. Huh? Most of the speakers will be from UP. That has been already sort of decided by the national body also, that the local will be more, and you have to call one member of the national body. I agree. So, but you are already the president. So you have that platform of UPISG. If you do it the next year, you have 2 years of platform. See, here you are the president, then you are the organizing secretary. If you be president and then you do a conference and you are the organizing secretary, you have 2 continuous years. Okay. So you are only bidding for the workshop and not the UPISG?
No, but what I'm saying is that is fine. See, Dr. Malay, when somebody organizes a conference, it depends how comfortable he is to doing X to Y, Z in addition. Always bigger and greater is better. So आप जो बोल रहे हैं बहुत अच्छा suggestion है. It is done. You do it.
हो गया
बढ़िया है, अच्छा proposal है, करिए ना.
तो हो गया खत्म हो गया ना. थैंक यू.
Yeah, that's fine. That's fine. No, that is very good.
हो गया, थैंक यू. हो गया.
Has already been done. You did that, na? 2018 Endocon has been done, okay?
Now, can you conclude? नहीं, ठीक है. I think, I'm sorry. हाँ, क्या?
So now we will discuss in the dinner.
Now what happens is organizing secretary and
So Dr.
president is now request president-elect that have to close down and start the next function. So therefore, can we close it down until?
See.
Bidding तो हो गया भाई.
You start the thing.
पहले मीराट हो गया, उसके बाद गोरखपुर हो गया.
स्टेज के नीचे बात करते रहते हैं. गोरखपुर. You start the stage. We are talking here only.
नहीं, आप पहाड़ में करिए मिड टर्म कॉन्फ्रेंस ऑफ यूके एंड यूपी. हो गया. आप जब मर्जी करिए. ओके. हाँ बिल्कुल. मिड टर्म कॉन्फ्रेंस ऑफ यूके एंड यूपी.
करेंगे, कानपुर करेंगे. मौके.
Sir, 24th UPIC goes to Dr. Malay Sharma and 24 UP combined will go to Mussoorie.
हो गया.
Stage, you can come down and talk.
You see, more conferences will be good.
See, the conference is continuing here. They are setting up the stage.
No,
the AG meeting is coming here.
Dr. Kejriwal, conferences will be good to take the society up. You do a mid-term.
So the